Welcome everyone. So I'm going to kick off our Integrated Care Board meeting this morning. We've got a few welcomes and a few apologies to do, but I'm going to do the welcomes first because that's much more pleasant, isn't it? So I'm going to sort of go around the table here. We've got Ella. Welcome, Ella. You are standing in for Steve, and you are the Strategy Director for RCHT, is that correct? Welcome to you. We actually have Neil. Now, Neil is joining us as a former board member today because, Tim, you're stepping back and you've done a huge amount of support and work for us. So I'm very grateful for everything you've done for us, but Neil will be taking your spot, yes? Yes. So, Neil, is there anything you wanted to sort of say as your intro to colleagues, as you're going to be a colleague of people?
So I'm Director of Paramedic Practice at South Western Ambulance Service. Live in Cornwall, so unlike Tim, I'm not travelling across the border, so I've got a vested interest in the care we deliver to patients in Cornwall. Hopefully I can be a valuable member of the group.
Thank you.
Welcome.
Welcome to you. Obviously everyone knows Juliet, but Juliet is here for an item later on, but I'm pretty keen for Juliet to be part of the whole exercise. Advisor to us, particularly to Kate and I and Carolyn, in terms of corporate governance, and has done a large piece of work and with colleagues across the whole system, I have to say, in putting together some of the work on joint committees. So welcome, Molly.
Thank you. Good morning.
All right. Now we've got Mel from Devon Partnerships joining us. Debbie later to be part with you, but she'll be joining us later, not now. I take it yet. Okay, so I'll say that to her. We've also got, I see he still hasn't quite arrived yet, but if you see a gentleman walk in, that'll be Stephen Otter, who is the chair of the South West Ambulance Service. So delighted to see him down here today and in person. Had some great conversations with him. I think that's everybody who I should have welcomed. Missed anyone? No? Great. Caroline, if you can take the apologies from those who we know on there. We'll get into the thrust of the meeting. So I thought before we start with the usual declarations of interest, I thought we'd start with a bit of a happy birthday. So I've got a short video to kick off because I thought we'd celebrate the NHS's 75th anniversary, but also celebrate the fact that what we've got is an amazing workforce that make this up. And this is part of the 5 vignettes that are in the pack that I hope you've all read. For those who haven't spotted it, particularly the public maybe have not spotted it, this was of course shown at the Glastonbury Festival. It's created by Somerset, so we thank them. But we are mentioned in it. But I thought just a fantastic moment.
Pause for a moment, just for 1 minute. Think of the NHS. Tell me, what do you see? I see an army of men and women dedicated to you and me, caring from Somerset to the Isles of Scilly.
It's Richard, one of the paramedics at Black.
The place you call when you're in pain. I see humanity. I see care. I see the people who are always there. I see their courage in an emergency, when there's tears and it's bloody. I see 75 years of unparalleled medical advancements admired around the globe.
The marvellous thing is that I don't have to worry about whether the patient can afford it.
An institution free to everyone, whether you're rich or poor, young or old. I see people rising to the challenge. Tuberculosis treated, polio vaccinated, babies being incubated. I see champions being clapped on, fighting an invisible enemy. COVID was our biggest adversary. I see 350 different vocations, all of them heroes. The pharmacist, the oncologist, the receptionist, the pathologist, the nurses, the doctors, the cleaners, the porters, treating mothers, fathers, sons and daughters. I see you and me. Just like us, yet they came from distant sea. The NHS is their family. From Jamaica or New Delhi, they came here for us. They were a vital growth of our medical body, part of the hands that bring remedy. Those hands that caress the pulse as it passes. Those hands that hold the other end of the phone when you're all alone.
The hands that lift.
The hands that lower.
Those hands that steer the wheel in an emergency. Those hands that pull new life into reality. Those hands that shelter until the babe can breathe easily.
Those hands that care.
The hands that heal.
These hands are blessed. These hands make up our NHS.
Happy birthday, everyone. Okay, so let's crack on. So this is Stephen, just walked in. Stephen is the chair of SWAST. Welcome, Stephen. Okay, so declarations of interest. Is there anything anyone would like to raise on the declarations of interest? Yep. Lovely.
But if for those that aren't aware, so I'm a trustee at Cornwall Air Ambulance and a director at SWAST.
Lovely, thank you. Yes.
On the agenda, we're talking about dental services. The practice that we were talking about, I'm a private patient with that practice.
Very good. Thank you. Anything else? No? Thank you very much. So we'll move on. So we've had, I think it's two questions from the public. One we're going to go through now. I think that we've agreed with the other person that we're going to go back to them on that. But Chris, you're going to deal with the first question and the answer, please.
Which the member of the public is happy for us just to summarise, because it's a long question. It's around discharge pathways and targets, but the member of the public just wanted us to note the specific questions, which I'll read out. Can the board confirm the following? 1, the actual numbers of patients, not percentages, for whom discharge capacity is planned on each of the pathways in 23, 24 and 24, 25. 2, that it's confident that the extra 172 care package being planned is sufficient to support the 50% increase in patients on pathway 1. And 3, what changes in healthcare provision will allow the 50% decrease in numbers of patients requiring rehab or reablement or transfer to a care home. And we've agreed with the member of public that we'll respond to this question outside the meeting due to the complexity, and the response will be published on our website as normal and included in the September board questions paper.
Very good. Anything on that? No? Right, so let's move on. Thank you. So we've got 2 sets of minutes to approve, because we had an extraordinary set of board taking place during the month. So can I go to the 8th of June, first of all? Is there anything on the minutes relating to the 8th of June anyone would like to raise in terms of accuracy or for change? No? Okay, we'll take those as read. Thank you. That's approved. And then we had the extraordinary meeting held on the 28th of June. Any accuracy or changes people want for that? If not, I'll take those as read. Okay, done. Thank you. We'll take those. So let's move on to item 5. So where's Lucy? Oh, there you are. Lucy, I've rather rudely stole one of your 5 vignettes, which I apologise at the very start, but over to you to walk us through the general topic of the 5 vignettes, please.
Hello, everybody. So today's series of films cover a wide range of areas, from primary care and the social prescribing, in particular a really innovative and supportive project to support young people. There is also Argyle Fit, to get that right, a really well received support and public health programme that is really supporting men in particular who've high BMI, and we met the team and it was just a fantastic day to actually go and see people. And I know that the number of people attending the football in particular is really high, and it was just really lovely to see. We've also been over to the Isles of Scilly, you may recall, in May, and we visited and spoke with, and there's a vox pops from a number of different people there with some particular asks as well, from the local dentist from Smile. So I just wanted to raise those for Chris Reed's awareness. In particular is the contractual and the number of people they're seeing over there. And I said that we would provide an update after seeing the board. And then of course you've got the NHS Somerset video, and also included a video made by our own Pete, which is a series of 25 voices capturing an audio documentation of people who provide really valuable services across our NHS. And as well, with Armed Forces Day in June, we cover the HM Armed Forces Veteran Group from Newquay, who provide a range of different support from surf right through to mental health. And it just shows a real diverse range of support across our systems.
Okay, so you'll all have had a good chance to have a look at the 5 of them. Any questions or challenges or observations that came out? I've got a few, but anybody first? Martin?
Thanks, good set of vignettes as usual. I think one thing that struck me on one of them, and it's quite a small oblique thing, I think it was one of the Isles of Scilly residents who was talking about a visit to outpatients on the mainland and how it had been a huge bother and taken 5 days in hotels. They also added that the outpatient appointment was actually a waste of time at the end of it all. And it just made me think, reminded me, where does our sort of outpatient transformation sit? Is that just with a trust, or is there anything else going on in terms of, I suppose how we are going to patient-initiated follow-ups, telephone or video follow-ups, generally trying to reduce that number that are seen sometimes by the public as unnecessary.
Look up with the Isles of Scilly with some military colleagues, because their risk tolerance is much higher than ours. And as part of that, we'll be looking at what people have to travel for and what digital solutions are in place so that people on the Isles of Scilly enjoy the same services as people on the mainland, but not having to travel. And in part of that, we'll be picking up some of the issues around radiography, because if it wasn't in this vignette, but if you hurt your ankle, it can be up to 2 weeks before it can be x-rayed on the Isles of Scilly. I also spoke to Emma Rouse yesterday about how we could use personal health budgets so that people could pay for their travel off the island, because that's another really big issue, that they have to book their flight via the booking office at RCHT, which means they don't choose when they go. And so we just need to we need to have a different mindset when we're thinking about the islands.
Okay, Chris?
That's exactly the sort of question and challenge we'll pick up by dealing with our military colleagues who are more experienced at sort of a remote model. So that's what we're working on.
In Penzance, I think that applies to people who live remotely in Cornwall generally, and this is about services being provided closer to home. And whilst digital solutions are a solution, they're not the only one. And the issue is around an equity of distribution through specialities across the county in terms of outpatients.
Yeah, and I went over to St Mary's 2 or 3 times to do their dignity audit. And I think one of the things that, like you said about the radiography, that was one issue, but the 2 other things were somebody needing to be conveyed back to the mainland, who needed help to get on the steps of the plane. The steps for the plane will only take the weight of 1 person, so they have to be able to get up independently, or they can't get on the plane at all. So they have to then go on the ferry. And then there was a little while ago now, obviously, but somebody who'd been discharged in pyjamas from Trelisk, having to come back over to the Scillys, and who was discharged too late to get that day's transports. Just
Mary?
Very well. I wonder if Pete could turn up a bit.
So I'll tell you what it is.
I've
I've noticed a couple of people. If you could bring your mic actually closer to you, because it's clearly not picking it up, I'd be very grateful. So,
could I just summarise all of those comments? So we do have a piece of work. It has kicked off, and we will be working with people on the islands, and also with our providers, both RCHT, CFT, and our dental and general medical services providers on the island, to come up with something that is 21st century facing for people in remote places, which of course can then be applied to the rest of Cornwall. So it's a proof of concept really, rather than just an Isles of Scilly piece of work, which they're delighted about, that they're being used as a test bed for us to learn from.
so on the particular points that came out in those Vox Pops, do we intend to follow those through? Is that, yeah? So Chris, you're going to pick those up and let us know that we've at least tried to resolve them as best we can. Okay. Anything else on those? Yeah, Rachel.
Thank you. I just reflecting that there were the couple of vignettes, the Argyle Fit and then the veterans one, really sort of looking at
particular groups that have poorer health outcomes, and that's the purpose of some of these vignettes, isn't it? It's to highlight the work that is underway, and I thought they were really good examples, and also recognising that there's some really passionate people, and Mark, who leads that veterans group in Newquay, and who was also at the veterans conference, people like that, real community leaders. So I sort of noticed that it's really good to champion and hear from them. But the Argyle Fits is something that we're really proud of, that we are continuing, but it is targeted, but it does, I think, show that preventative approach, the long-term weight loss, prevention of diabetes in that higher risk group, because men have shorter lives than women.
Any other? Yeah.
Which I thought was a really interesting vignette. I just wanted to make the point that I read an article recently by a professor of psychology in Oxford who had herself lived through anxiety as a young person. And the key points here were early intervention. And we are looking now at a situation where in some schools, children who are labelled with anxiety carry round with them a label that says, "Don't challenge me, don't ask me questions, don't put me in difficult situations," which is not addressing the issue of anxiety, because life is anxious and we all have to learn to deal with difficult and anxious situations. So these interventions and social prescribing are really, really important, and we need as many of them as possible for people that are directed towards not just being kind to people, but actually gently challenging that you can get through this.
Okay. So, Lucy, yet again, another set of, as Martin said, fantastic 5 vignettes. Thank you for doing these for us. We did talk a while ago about how you're going to collate all this and bring it back. Can we just make sure we do that before Christmas? I'd be grateful. I appreciate, as everyone knows, we're not having an August board. September's going to be full on for a variety of other reasons. So if you can just start to think about when you will collate all this and bring that back, I think that'd be fantastic.
We've got a waiting list of people who want us to come and visit them and film them. So it's word's getting around, so that's really good.
Which is great. Okay. Thank you very much. Shall we move on? Yeah? Lovely. Thank you. Let me move on to my chair's report. So just a couple of things I want to sort of tease out, because I take it as read. One is just to, I'm sure you'll have seen it, but to look at the performance, Mari, and of how things are going so well, if I may put it that way, in key areas at RCHT. So I didn't know whether you wanted to touch on that as we go through here or later, but just let's celebrate the moment, really. It's more than a blip. So
it's not just RCHT, it's a collective effort.
Oh, absolutely. Yeah.
And I think we've all got our breaths held at the moment, just making sure we can sustain it. But that is not to say this isn't a brilliant moment. So it's thank you to everybody, otherwise we wouldn't be here.
Absolutely. And it is a system solution. Completely agree. Only other one, and while you've got the floor, Mary, because of the items that are on here, and Molly's going to talk to the risk management assurance work, I put into my chair's update about the discussions that have been going on across the NHS boards down here in terms of joint committees. And I know that whether you wanted to say something on that.
Yeah, Margaret might want to as well. We've certainly had a good opportunity to have that initial discussion, and thank you very much to Molly for the initial paper, and actually to other people who've been involved in that. So we had a good discussion at board, and our board is broadly supportive of the direction of travel. We did note the risks and want to be sure that they're fully considered and mitigated, so that we are more comfortable than we are now. We're happy with the direction of travel, but we just need to see what we're going to do about it. And our board was supportive of option 1, but we do need to ensure the importance of the quality ahead of the finance. And that's not to say they're not both important, but our board was quite exercised about that point. But thank you for the work done so far.
Margaret, would you like to take the opportunity, or?
We were similarly inclined to go with option 1, but our big concern was the same. We can't separate out the quality from the finances and the finances from the quality, and that is the risk. We also see a lot of benefit in, particularly with the CQC framework and in the collaborative working. So we were happy to go with the option. Skepticism about whether we'll get there for October, and therefore some real concern over whether we shouldn't be a working group immediately focused on just the soft metrics and position in advance of the joint committees being up and running.
Thank you. Well, we're going to pick it all up. Thank you, Margaret, for that, and thank you to the two boards. Thank you also to the group of people who have actually worked on this, Molly, in your capacity, and I know the two company secretaries have been key to this, but also the wider teams and the chief executives, etc. If you wanted another classic example of collaboration, this has to be a key moment. And of course, if we take this forward, I think I'm right in saying it's probably the first in the country to do this. Is there anything you'd like to add?
Yeah, I just think we should mention Steve Williamson's leadership on this. So he has very much pulled the two trusts with the ICB together. So I think we should formally note that.
Yep. Very true. Thank you for that. Okay, anything else that you want out of the Chair's report? If not, we'll move on. No? Thank you very much. So, Kate, over to you for the Chief Exec's update, please.
Thank you. So I'll take the report as read, and I'll just go through a few reflections. So the annual general meeting that we'll hold on September the 14th, we'd like it to be a revisiting of our True North event, so that we have the opportunity to reflect on what we've done in our first full year of operating, and to make sure that we involve the people who we work with and for, so that it's more of a reflection of what's happening in place, rather than just the outcomes of the first year of the Integrated Care Board through its AGM. The Integrated Care Partnership has had its third meeting in public, I think it is, and we're focusing on the outcomes of the 10-year strategy. So the strategy is in place. We've got a piece of dedicated work so that we can plot over the next 10 years that we're making progress. And of course, we are a Marmot region, so and the advice from the Marmot team is to make a difference to the health of our population, we should be looking at school readiness education and how we get our young people ready for meaningful employment, because that will make their health better. The Armed Forces Conference, I attended right at the end to do some themed feedback. One of the things I just wanted to mention is that we have signed the Armed Forces Covenant, and there was a bit of a lack of understanding in the room really about what it meant. So the bullet points that are under 3.3 are very clear around our moral obligations and our legal obligations to our population who serve in the armed forces and their families. And then John and I attended the ICB Chairs and Chief Execs Away Day with the NHS South West senior team. And I think it's just worth reflecting that the integration and the collaboration that we're trying to bring together locally is very much what's being driven by our South West regional team, that Elizabeth's starting to call it the South West Way. That we, each ICB will take a lead role or responsibility for the rest of the region, and that we knit ourselves together as a collaborative team, delivering with and for each other, which gives us a greater strength over what could be some difficult years ahead. Planning integration of service in the Isles of Scilly, I've covered that, but I do think this could be really exciting, and at a time when we could do with a bit of bounce in the things that we do for our tired people, freeing their minds up to the things that we could possibly do rather than being constrained by our current ways of working. So it could be a good opportunity for our CHT, CFT, general practice and the ambulance service to start coming together around team training, not individual discipline training. And again, if we could pull that off on the Isles of Scilly, it's got massive applicability to the rest of the county. And some work that Chris is going to talk about later around getting ready for winter. We're involving the Department of Rural and Hostile Medicine from Lancaster University, because they are effectively GP extensivists. So they and their risk tolerance is nowhere near where ours is. So it'd just be a good provocation around whether we are getting the best out of our talent in Cornwall. We've launched the first phase of the consultation on the first phase of the ICB restructuring. We engaged with unions about 10 days ago. All of the affected staff by phase one have been spoken to pre-launch of consultation and have had one-to-ones subsequently. And I just think it's timely for us to reflect on the fact that our people are feeling really wobbly, and we need to make sure that we're supporting them whilst also making sure we've got the most functional way of working across our county for our people. And our people is the last item. The long-term NHS workforce plan is out. We will be needing to respond to that, and we'll need to respond to that in the light of changing models of care. So it's quite a big ask for our HR and professional lead colleagues, but an exciting time. Thank you.
Thank you. Any questions? No? Pretty clear, Kate. Thank you very much. So let's move on to agenda item 8. So this is the paper on risk management assurance update, which Carolyn and Carol's going to lead on. Just sort of say a few observations before we start on it. The need for this, of course, as we start to think about the fact that when we were celebrating the NHS's 75th birthday, I should have also said, of course, we also celebrated our first birthday at the end of the 1st of July. So there's something here about us doing a review of our committees, which we're going to do, but we're also going to look to do, with support of Carolyn and the team and Kate, is how we're going to do a sort of self-assessment of ourselves as a board as we go through that between now and the end of the year. So as we're starting to do that, this really has opened up over recent months the discussion that has looked about if you're setting objectives, you're setting priorities, have you got the appropriate risk assurance frameworks in place in order to deliver those outcomes. So this piece of work, which I'll hand over to Carolyn now and to Molly, is to try and pick up that as we go through the next few weeks and months. Carolyn, over to you.
Okay, thank you, Chair. So I think you introduced that quite nicely. There's not really much more to add to it other than John has said this is probably going to become a bigger piece of work around how we work together as a system, looking at the assurance framework, looking at the risks, and obviously predominantly those will start with and around the work that we're doing around the joint committees at the moment. So effectively, we're going to take the paper as read. If there are any questions, then I'm going to go to my learned colleague Molly for any responses. So.
Yeah, Kate.
Could I just make a point? So shortly before the start of the meeting, Margaret and I had a brief discussion around how we can use our knowledge of risk that we've got in the system with what we're seeing come out through our operational delivery, and that we have a quarterly system oversight meeting that goes beyond the exec interface into a full system oversight meeting, so we can see all of our metrics lined up against the risks that we thought we might have and those that are manifest. So we will set the first one of those up for September, and then as this work progresses, we've then got something to compare how we're moving together to make sure that we're risk managing as we get closer to winter.
So can I have clarity on that? You're talking about the SOM that we've been discussing as part of the board. Are you saying that for September?
Yes, if we could do that, and we'll have our regular system oversight meetings with NHS England from an executive perspective, but there's just one time quarterly that we come together to look at our performance.
Thank you for clarity.
Any question for we? Yes, Mary.
John. Thanks, Caroline and Molly. I think this is a really helpful framework for us. We've needed it, so it's really good to see it here. I really like the clarity with which you've laid it out, and it feels organised and in control, and that's what we want a paper like this to feel like. So it's great. I think when we come to populate it, that's the point at which we may have to have a bit more of an in-depth discussion, or maybe not this board, but appropriately have that discussion, because I'm just aware we're bringing together the risk appetites of different groups of people. And I know both Margaret's board and mine, and I know others, have done a lot of work on risk appetite and exactly what it means. So I think there's something that might be helpful to us, John, as a board, perhaps prior to getting into the absolute detail of the populating this around, just maybe a short session on what is our risk appetite, and do we share that? How do we bring that together?
So
but super paper, and thank you for
so
it.
what I'm going to do is I'm going to go to Neil in a second, but Molly, if you can just get your mind around how you now want the next session to go. You've got about 20 minutes on this, so if you want to use that, but Neil.
I was very interested to read this paper, and it was hard for me not to divorce thinking of strategic risk shared by organisations with risks that are shared every day by people working in an integrated and collaborative fashion. And I suppose what it really for me needs, and I think this picks up with what you've just said, is a surety that people can be very honest about the context and the reasons why risk, as it stands within organisations in particular areas, exists at present. Because there is always a danger with collective working that by saying it's okay now, we're sharing the risk, you haven't really addressed the context and the reasons why the risks existed in the first place. So I think my plea would be that in any work we do around providing good quality and risk sharing and risk approach, that we have a culture of being really honest about why things exist at the moment.
But then I can see Emma wants to go on there as well, but you go first.
So one of the discussions we've had with Professor Stuart Maitland from Lancaster is around what we offer our people in terms of the risk management structure that they're working within. And if we're asking people to do things, then we have to explicitly say we are going to back them, and it has to be a compact between us and them. And I think if we can have some of that built into this, our risk management framework, it would give comfort to all of our people, including the third sector, who sometimes are just saying, I need to phone somebody to let you know what I've done. And I do wonder whether there's a benefit from having somebody like Stuart in the room with us to just keep grounding us in this is what your risk management framework is needing to do for your people to be able to deliver.
Okay, so respond please now.
This isn't working very well, sorry. I don't know whether this is such, I tend to say things that I think that's really obvious, but examples of that are that people who share risk collaboratively often feel that because they're collaborating across a number of organisations in their team that they're working in, that they feel supported. If you're going to look at a really effective matrix framework, you need that to be as strong across and as strong up as it is across. And that is where risk often falls down, because people feel they're supported across, but they're not necessarily supported from above and below.
Okay, thank you. Emma?
Thank you, Chair. Yeah, totally agree, Neil. I think, could I just ask for a practical addition to those discussions, which is often left out of the room, are some of the recognised channels, those people on the ground to whom those risks are expressed. So I'm thinking of the System Freedom Speak Up Guardian piece of work that would feed into this as well. So it's just a plea to include those colleagues in those discussions, please, because actually they are part of dealing with the operationalisation of those risks that are expressed and what we do with them at a day-to-day level.
So I really welcome the paper. I welcome the clarity in it, and I also welcome explicit reference to things like estates risks. And colleagues will know from the CFT CQC report last year that CFT as an organisation is carrying considerable environmental risks, and we are being greatly supported by NHS England, actually regionally and nationally, with trying to resolve some of those matters. But they are nevertheless matters that as a provider we can't resolve solely on our own. So actually being able to have a forum where we share those risks and then the solutions collectively is really going to be very supportive. So I endorse the recommendations.
So Molly, what a lovely place to start with so many nice things being said about a piece of work. So why don't you continue on in that vein, please?
This point, because I think it's very important. Sorry, I don't know if it's working out. So I think that the principle of the paper is nothing should be on this shared document unless it's recognised across the system. So I think estates is very much an example of risk that ought to be escalated across the system. So I've already got the BAFs and the core risk registers of all the organisations and working on those to collect a single document. So I think it's important for people to know that it's not coming from the ICB, it's informed by the documents of the two trusts, primarily.
Another classic example where this only works if it's done together and we agree it together, and then we all own it together. Yeah. What would you like to see next? Because before I get to the recommendations.
So I think taking Mari's point about the risk appetite, I think we do need to maybe have some time to reflect. So I know we've got an August Board Away Day, so we need to maybe think about how we structure the day to look at where we are now versus where we think we should go with the risk appetite.
So part of the discussions that have taken place, Mary, is to actually think about how we use the day that we're not having the formal board meeting to actually, depending on how everything went and goes today, is to then think about how we frame that day together, focus on this, and maybe use that as a sort of a launch pad to be able to sort of take this forward. That's what you want to try and do, isn't it? Yeah. Rachel?
Yeah, thanks. And a really useful discussion. I think I remember when we talked about risk at the away day, there was also that link to the prioritisation of the things that are discussed and action taken and how it shapes the board agenda. And I'd quite like to see a stronger link to that within that. So the sort of so what? So once you've got the risks, you've agreed them, system risks, how then do they shape the work of the board going forward?
Sorry, and for me, it's also about making sure that whatever mitigation we've put in place has actually changed the risk, and how has it, and can we see that? Not for blame, but because if it hasn't, we need to change the mitigation. And I think for me, that's sometimes missing. So if we could get that in as well, thank you.
So Rachel, just to pick up on that point, where I was trying to go in my intro by talking about the objectives and priorities and then leading that, is I think when I look back over the last year, I think collectively we've come a very long way. But as we start to look to the next year forward, our board agendas need to be more informed, structured, based on our objectives, our priorities, and the risks that go with that, and that then flows with the agendas. It needs to be more empirically driven in that. So I think what will come out of this will be a much better governance, integrated way of working that will drive the better outcomes. And our board time will be driven by the things that are most important to effect. So I'm hoping that's what will come out of that. Okay.
I just wanted to reflect at this point that when we're talking about risks, a lot of what we'll be talking about are the operational delivery and financial risks that we see as part of delivering care across Cornwall and the Isles of Scilly. I'd hate us to miss the inequalities risks, that if we don't do some things, then inequalities and the impact of that will be greater in some parts of our population than others. So I think we might need to segment our risk profiling so that we can have our heads in the today and the tomorrow agendas. And Rachel, I didn't know whether we could start using your DPH report as our state of where we are, and then to prioritise the risks that as an ICB we should be addressing as we're going forward.
Okay. And given the debate that we just had, we just, I think, also got to be cognizant of the fact that some of these strategic risks are going to take a long-term burn to do, like estates. Not going to sort that overnight, but taking Margaret's observation, which we welcome earlier on about SOF, and the more immediate, it's got to balance the short-term, immediate, and with the long-term. Okay, so should we move to the recommendations on this paper, if we feel everyone's had their full support behind this? Okay, so the recommendations are to note and receive the assurance update and development of the risk management assurance framework, and to note and approve the associated implementation timelines, with a view to triangulating all of this, just for 100% clarity, back in September. So when we get to talk about forward plan, we're going to have to think very carefully what's on our September board meeting, so we have genuine quality debate about the things that are going to really shift the dial. And this is clearly going to be one of them. So are we happy with that? Lovely, very good. Thank you, Molly. So let's move on. Now we move to Carolyn and Lucy on the draft citizen engagement strategy. So again, we're going to take the paper as read. You've got a bit of time to walk through a Q&A session, but do feel free to do an intro if you need to, as a summary.
No, so I don't believe I need to do an intro, Chair. Thank you. I'll just hand straight over to Lucy. The only thing I would just acknowledge is there's been some great work done around this so far, and this is an evolving piece of work as we move forward. So contributions are greatly welcomed to everything that we're doing. As I say, we've had some positive feedback around it, so that's been really helpful. Thank you. Lucy?
Thank you. So this strategy sets out how we plan to put people at the heart of everything we do when we're planning, delivering and improving services. And what is presented today is a living strategy that will be shaped by further conversation, further engagement through the year, we're at the moment doing a piece of work called our Community Conversations, which is reaching out to people most impacted by health inequalities to hear from them. And we're trying out new innovative ways of engagement that will help shape what we do in the future. It also follows NHS guidance and what's required under the Health and Care Act for integrated care systems and integrated care boards to deliver. And this draft strategy sets out creative and empowering engagement opportunities that make the most of some really good established networks and ways of working that's really already happening both across Cornwall and the Isles of Scilly. And we want to work and support and fill any gaps that may arise. We also need to be aware that we're already doing some great collaboration. You may be aware that we went to the Royal Cornwall Show with our colleagues across both CFT and RCHT and many others too. And we're doing lots more over the summer. We've got a Hearing Loss Cornwall event with colleagues invited from Health Watch and across our system to attend and hear from people at that event. And we're doing some great work supported by colleagues from Public Health and Cornwall Council and the Isles of Scilly Council, and just some real practical things to help us. So that's, for example, using the Let's Talk Cornwall digital platform to run our strategy engagement that's running at the moment for the ICS strategy, and also reaching out through their comms channels to reach many different people. For example, the practicalities of sending out our survey recently through Cornwall Council's resident newsletter and our RCHT's comms channels and CFT's comms channels really sees a measurable uptick in results that we couldn't do alone. And that's the power of what we're trying to do, is really reach out and work across existing networks and utilising our partnerships to reach as many different people as possible so we can shape the future of our health and care services as we move into the future. What's in the strategy is a new engagement framework and functions. As I explained, it's designed around existing networks, but we also want to expand some areas that could be improved in terms of reach and how they work. So, for example, the role of the patient participation groups across our areas and across Cornwall and the Isles of Scilly is a really good area for us to develop and really hear and understand what's pertinent at place. But we also want to establish new functions, one of which is a new People Alliance, and this is about actually coordinating people who are actively engaged across our system into an alliance that can feed back and we can keep in touch. And we can also grow and nurture those people on that alliance to become more actively involved, as well as the role of the expert reference groups. There are so many fantastic groups across our communities who know medical conditions, age group related or life stages, and we really want to utilise that network. And I really want to say a special thanks to members of our People and Communities Network, which are our engagement leads, our patient experience leads from across the network, from SWAST to our NHS providers, right through to the Cornwall Voluntary Sector Forum and many others in between, because they have been helping to shape this strategy and feeding back and connecting us with people who will be able to join our expert reference groups. An important part of the strategy as well is our new mystery shopping function. So the aim is that we would like to utilise people's existing appointments across all of our different services to provide some user and journey experiences, and we'd like to feed that back into the system. As well will be a digital way to engage, which is utilising the Let's Talk Cornwall programme, digital platform, and then an ongoing annual engagement programme. We will be doing and getting out to our communities all through the year. So if there is priority or statutory or specialist engagement that we need to do and our partners would like to be part of, they can utilise that programme too. And how we'll share that information from all of our engagement activity, all the valuable insights and data that might come from our patient participation groups will be through a new engagement and insight dashboard that we're working with the Academic Science Network and wider colleagues across the network to develop. And in time, we'd like to see how that can tie in with the public health data, infographics and maps. So it's quite an ambitious strategy that's before you. And I would really welcome your feedback today and any questions. As mentioned at the start, this is a living draft document and it is open for change and updating as we learn and hear from you and your colleagues as well. Thank you.
Excellent. Fantastic paper, by the way. Thank you for that, Carol.
Thanks, Chair, and thanks, Lucy. An earlier draft came to the Citizen Engagement Committee a couple of months ago now, and I just want to recognise the additional work that Lucy and the team and all the colleagues have done today. So I mean, I'm not going to repeat what Lucy said. It's a living document. It's a changing document. We've all got such documents in our organisation, so the bit I want to say is not particularly about what's in front of us today, Lucy. I want to commend that work, but I suppose I just want it noted now about what are we now doing with it. So, and we're all in large organisations whereby, and it's my background for many years, where these types of strategies need to sit as importantly alongside all the other senior strategies in the organisation. Otherwise, it will just sit alongside, and then when things go wrong or things don't go according to plan, they'll pull it out and say, oh, that's what we should have done. So it's really important that we as individuals, I think often organisations can sit behind a strategy. So I think all of us in our day jobs need to take this strategy. It's not Lucy's job necessarily to make it happen. She's gathering information, and I'm interested in the impact and the change to quality and pathways of care and patients. We're doing a lot of listening, but then what are we doing about it? So I would like to ask Lucy to bring back with the vignettes the earliest of differences that we're making through what you're hearing. Doesn't matter how small it is. It's like anything. The smallest change or change of a particular group of people, whether it be area, whether it be by clinical subject area, the difference or change we're making will actually start to open it up. So that's what I'd like to encourage Lucy and the team to do. But otherwise, I commend the strategy, and I'd like to see the next steps as soon as possible.
Thank you. And Lucy, I think it's a really sort of comprehensive and logical strategy. So I really welcome it. It's really clear. And I know that the council will carry on working with you and colleagues to sort of develop that and make sure that we are taking all opportunities to bring in the insight from council members and partners as part of the ICS. I really welcome this structure that looks at the co-design, co-production, the ladder of engagement, because that's what it does articulate. A lot of the ambitions are around engagement, which is the first ladder, and consultation, but that aspiration to really go more towards a co-design and co-production methodology, I think, is really what I welcome in particular. And we've seen that in action, and I think we've seen some examples that it has worked, so we could really bring that back into the strategy to illustrate what that means. I think I'd really welcome that. On another side, around some work that I've done with more national charities, I wonder if we should be also looking to health charities, British Heart Foundation, Diabetes UK, other really experienced organisations that operate in Cornwall but not sort of a commissioned, they're national, to bring in their insight, and that may be just something that I'm happy to talk about. But I really commend the approach, really support it from my role and also the councils, and look forward to working with you on it. Thank you.
Susan.
A great piece of work. I think it's really important to say, and echoing what Carol says about the and so what of what we do, but it's actually a very neat way to pull together what it is we're doing for our population, which will serve us well when it comes to our CQC assessment that we'll do, because it's a way of bringing all of that evidence into a very a neat place, for want of a better phrase.
Hello?
Sure, I can hear me. Lucy, it was really just an offer around, I couldn't see it mentioned here, you may have already be aware, we have launched last month at Royal Cornwall Hospitals the Patient Leaders Forum. So it's another place, like Carol said, that we can hopefully just help bring the strategy to life. And I think from our citizens' perspective, the more we speak as one voice, the more coherent it will be. Thank you.
Thank you very much. We've got Debbie.
Yes, thank you. Again, I welcome the strategy. And I think it's really, really clear in terms of the what and the why and the how from a strategic perspective. But if I'm a member of the public and I read this, I'm not sure it makes an awful lot of sense to me, because I think it's written currently. This isn't a criticism, by the way. This is I'm aiming to be really constructive, but I think it's written in such a way, using language that speaks to us but doesn't necessarily speak to all people who use services. So we'd be really happy to support, for example, with an easy read version, or actually asking some of our experts by experience in some of our services to actually give some meaning to this, so that we can demonstrate that the intent behind this, and I know the intent is there, Lucy, but the intent behind this is to engage with people in ways that have meaning to them.
Yep.
Really welcome the intent of this engagement piece. Can I just pick up one thing? It's on page 4 of the main document, and it says we can prove people are at our heart. Every new service is co-produced with local people. That's great, but I think sometimes that implies that's what we're going to do with you, whereas actually local communities have their own kind of issues and concerns that they bring to the table, and therefore it should be extended to existing services that are causing concern can be co-produced with people. I think we just need to be a bit broader in the acceptance that we don't set all the agendas, and if we're really going to engage with people, that we want people to set the agendas. Can I just take you back to the board away day we had recently? In that away day, Emma and Juliet led a discussion on personalised care, and I think one of the messages that we got from that was that personalised care is not about just setting up ways of working that are strategic, that get people sort of the sense of personalised care. It's all our behaviours that matter. It's in the way we behave in the engagement sphere. I worked with a CCG user group a little while ago, probably about 12 years ago. I can't remember now. And to my shame, I was part of disbanding it because they so felt they weren't being listened to. They felt it was a one-way process. And I think it's really important that in all our behaviours, and people don't know who to engage with, so actually they actually often engage directly with senior people in our systems and organisations. And I just put in a plea that we respect that. We don't see engagement from the public as a threat. We see it as an opportunity, and we always take care to acknowledge and thank people for the time they're spending in bringing issues to our attention.
Yeah, Mary?
Just in response to that, we need a system. You said we did kind of a way of responding, don't we? And largely, Debbie, you've made my points, but I just wanted to respond to what you said, Carol, about it really will be worth us having examples of where whatever the group is has made a difference. And for instance, our Maternity Voices partnership has been really effective, but it's been effective because we've made them part of the operational team effectively. And that has made a very big difference. So I think that idea of having, again, it's the closing the loop, isn't it? What did we do? What did we hear? And what did we do about it? But I think the other point is when we can't do anything about it, that honesty of being able to say, well, these are the choices we're currently making, and they're not going to include that, but we will reconsider, or whatever we say, because the problem with any kind of user forum, and I've been part of many, is of course we'll say what we want, but it might not always be possible. But we need to hear what it is people are needing. Thanks, John.
I was going to talk about Power BI, but I'd just quite to reflect on a few things first. So the demonstrating that we're listening is really tricky, isn't it? But one of the things that I am really clear about is we've had loads of patient vignettes now, people's stories. What have we done with them, and how can we show that we're listening? So that would be my first test of whether our strategic intent is being met by our practical doing. And Mary, putting maternity voices into maternity, it's worked because they haven't become part of a prevailing culture. Their voice has been really loud within maternity. So how do we have, I don't like the use of the word empowerment, just because it's got horrible connotations for me, but how do we have confident people with loud voices saying uncomfortable things and it being okay? And I think that's part of our engagement strategy. Needs to make sure that that's at the middle of what we do. Margaret and I spoke earlier about it's not always the good news we should be looking for. Sometimes we should be balancing that with the things that aren't quite so convenient. And on the back of that, Kate Kennelly and I had a discussion about how we could use the Power BI that's in the council with our developing Power BI under Calvin's leadership, so that we can give John what he wants from a single version of the truth, which isn't my understanding of it. It's the state of the county of Cornwall and the Isles of Scilly, how people are, how they're living, what they want, what their preferences are, and then how we're responding to that, which is a bit of a shift away from how we've done engagement with our people in the past. So I think it would be great if we could build that into this, so we've got a real structured way of bringing all of this to life and then doing something with it. And then the last point was just around personalisation. Neil saying it's around how we are and how we interact. It's also how we share our challenges. Like, we haven't got enough money to pay for everything. So how do we start talking to people around how we make care in Cornwall and the Isles of Scilly as good as it can be with the restrictions that we've got, so that we can have a proper informed conversation. That's all I want, Lucy. It's a great strategy. We can do that as well in the next few years. That'd be great.
So, coming back full circle to yourself, Lucy, but at the start, when we took Carol, she asked the question, really, we're listening, but are we acting? So again, if you could just come back to us with a clarity as to when you'll capture the vignettes and these other points, and we can have a real clear, not just this is the draft strategy that becomes the strategy, but also how are we now starting to look a difference by what we looked at. Did you want to talk about the Cornwall model now or not?
So when Julia...
We'll get to that later. Okay, fine. Okay. Anything else that you would like before I get to the recommendations, Lucy?
Been doing some interesting engagement for the community conversations and having some really tough and contentious conversations when we've been out and about. And that's been really, really good, because it makes people... And I've been inviting people from our commissioning team, our primary care team, to come and listen to. And that is what this needs to be. It needs to be something that we can actually, it's more than just a strategy that sits on the shelf. Absolutely agree.
It's a tangential observation. How do we listen to our staff about what they think about what's going on?
So in the new engagement framework is about including the really good, there's staff voice forums across all of the different providers and across the system. So we'll be utilising them as part of our framework.
Part of the mix. Okay. So happy to move to the recommendations. Yeah. So I think we've had some good discussion and feedback on the draft strategy. Before we move on to the next items in the bullet points there, when do you think you'll be able to come back, though, with the draft into a strategy? Are we talking?
So I'm looking to have those continued conversations over the next few months with partners and to set up the function. So I could come back with an update in the autumn, which is when I'm planning to. The new strategy will be finalised and the function set up by May 24.
Okay, fine. Because I think there's something in what Rachel said about the work that's being done with the council and what you're doing there. There's something that you mentioned with Kate and the Power BI and all that's doing. Something for me about really leveraging this.
Can I make an ask, just, and it might be unreasonable, but in October time we'll be looking at how we're going to spend money for our people in Cornwall and the Isles of Scilly, and it would be great if we could do some engagement around the relative prioritisations, that balance we've got between treating illness today in a timely fashion with planning services or an offer for tomorrow that means people can make better choices around what they want to do with their lives. So I think it would be great if we could plan something that isn't too ambitious for this first year of doing it, but if we do it jointly with our council colleagues around the health and care interface, and maybe with SWAS, because often our SWAS colleagues get left out, but they are definitely part of the delivery infrastructure for care around our county.
Very good. Carol first and then Rachel.
I just wonder if the strategy for 24 is too late, too long. Is it more around an implementation plan, whatever you want to call it, operational plan, whatever you want to call it, Lucy, and that can be 10 pages. I mean, the strategy ideally needs to be short and sharp and at a high level. I think your aims and your ambitions for engaging with lots of different groups is absolutely the right thing to do and very commendable. But I just worry that when we are moving forward with other strategies, this is still seen as a draft. And I think, picking up on the earlier points, once we've got the strategy nailed, we can then do a public facing version of that on one side of A4. What does this mean for you as a patient? So it's just a thought, really. I think
what I was hearing from Kate was an expectation that October would be.
Oh, okay, fine. I didn't hear that. That
No,
was
no,
actually fine.
was that, was I hearing that right?
So it's. I'd like this to be core to our planning next year.
Exactly.
So October would be our first foray into having a structured offer that we're working
Very
through,
good.
that we'll learn from. I suppose I'm not trying to set ourselves up for perfection at the
No,
first.
that's quite right too. Yeah, thank you. Rachel.
Yeah, I think I agree. I was just thinking about the forward view. You know, the again launching a sort of 5-10-year strategy, and as you say, I mean, it's almost sort of good. It's a good enough to underpin the work, but that's another opportunity, isn't it, to underpin that approach to engagement, and in shaping the kind of longer term view. And my other comment was about building trust, because there's almost a preemptive piece of work to enable communities that wouldn't normally engage, and I learned that through the vaccination programme, was you've just got to build that trust preemptively. So that doesn't mean that work can't stop.
I think that's right, Rachel. And when Juliet, I was going to mention it in Juliet's update around the West ICA, but we know that the Brazilian model, as we have been calling it, maybe we should call it the Cornwall model, because it should be ours, not anybody else's. We need to be looking at the marginalised communities that we need to engage with in a way they can be heard and feel they've got a voice, and that might mean that people like us aren't doing the engagement. So how we and Juliet's paper pulls out all of the data around our inequities across the county. So how we bring that to life needs to be completely guided by the places where the people with the smallest voices inhabit.
Which will be a great segue to the next agenda item, Juliet. So let's conclude these recommendations. So I think what you're getting, Lucy, is agree in principle. You've got partner commitment for further discussion on this. I think everyone's agreeing to that. And I'm just drawing everyone's attention to page 2 and your point about the new functions and engagement framework. You wanted people to agree the development of these new engagement functions. Am I right? Yeah. Everybody happy with that as an approach?
Just one quick question. The budget for doing all of this, has that been set, or is that to be determined when you, because it's very quiet on resource allocation in here.
So we're currently going through our restructuring. So part of the phase 2 restructure will involve the team that will be delivering this, but also remembering that we're looking to keep some flexible budget that would allow us to deploy it according to the things we need to in one year to another. So up front there might be more requirement for engagement to get it up and running, but then we might want to do it project or program by program.
It just was very quiet on that front. And
Good challenge. Okay, so I think we've agreed all 3 bullet points. Are you happy, Lucy?
Lovely, thank you.
Great piece of work. Well done, you. Thank you very much indeed. So let's move on to, now Chris, you're going to introduce this, although I'm sure Juliet's itching to do the presentation, but as you're the executive member, over to you.
It's a very, very short introduction to hand over to Juliet, but just to acknowledge the work that Juliet and her team are doing in the West, and all of the innovation that's going on there, but also the collaboration that Juliet's doing with her place partners and the other 2 places as well, noting Andy Sand sitting here as well, not in the capacity, but in the North and East, and Rob White in Central. So over to you, Juliet.
Yes, welcome, Juliet.
And thank you for giving me the opportunity to bring the update, because I'm quite excited, as you may have guessed. So I think the first point I wanted to just run through is that I've heard some anxieties that maybe our ICAs are developing in different ways, and I really wanted to bring a bit of assurance, really, that there are a lot of synergies across the 3 ICAs with a very strong purpose about place and people, and working in partnership with our widest partners and our citizens. So I just wanted to say that as a kind of forerunner, to say that we all may be going at slightly different phasings, but we're all very clear about the things that we have got commonality across for all our citizens across Cornwall, and those who are the Isles of Scilly, and also those who have services provided across the Tamar as well. So some of those bits of work that we sat down together as the 3 of us to go, well, how would we kind of bring that together in a way in a paper? And you'll see that that's around really building those local strong leadership at place. ensuring we're being very inclusive and including everybody within our place that have a voice, including people with lived experience. So that kind of sings to the last item. And building those trusted relationships, because if we can't have trusted relationships, we've got no foundation to build going forward. And that takes time. And I think that's just to say, I think the last year is really trying to make sure that's knitted together. The other thing is around for our team. So we've got that leadership, but how are we then in and allowing that and enabling that at a place settle with our neighbourhood teams? And I have to say our partners have been amazing about realigning their staff. So they are all cohesive around a geographical space. So people are working together in that neighbourhood team. We've got more to do for sure, but that's one of those things we think is a real key enabler. And how do we co-locate those teams together? Because what we know is those water cooling moments are really, really important. And how do you build those trusted relationships where you can phone a friend to say, I'm not sure, can you help me? And I think that's the culture that I'm seeing emerging, which is being supported by our partners. So a big thank you to our partners, because that allowable behaviour and permission we are definitely seeing at place. So I just wanted to kind of just pull that out. And then around our primary care colleagues and the primary care networks, very much aligned to our integrated care and absolutely integral. They are a really strong voice and need to be, because they are often the first place our citizens contact. So how do we support them going forward when they are under, in my particular area, unprecedented demand? So it's about how do we work together in a collaborative way for our citizens. Tackling health inequalities is also an agenda that is really high on for all of us. So we might be taking slightly different approaches at the moment, but we're all learning and sharing as we're going. So as things are working in one area, we meet every week and we make sure that we're sharing that information. So that's kind of the helicopter view, kind of now going down to the west and the Isles of Scilly. In the paper, I've tried to draw out some of the context for our population. We do have some real challenges around areas of deprivation. We do have a large number of groups that I think Rachel was alluding to and Kate alluded to earlier, which often do have health inequity. I think I'd rather use the inequity word actually than inequality, and often are not those people that we see in our patient participation groups, in our normal meetings. I'm thinking particularly around our fishing communities and our farming communities, who by virtue of their work are not always seen in those environments. So I think we keenly want to think going forward in our area, how do we make sure we have something that's inclusive and works for them? You will see in the paper I've used a phrase quite a lot around co-producing solutions with people that are proximal to the problem, and I think that's a real core within in the West to say we don't have all the solutions, but actually what we know is people in communities and our staff often do have the right solutions, and how do we bring those two things together? So I think that's one of our real key building blocks. So I did put in one of the slides, the tree that we use that was developed back in May 2022, which has got our two overarching aims. So that's people are cared for in their place unless there's a health or care reason to go outside of their place. And then people whose life expectancy is lower due to health inequalities are our priority. We use those for everything we are doing to test back. Are we doing the thing we said we do? So it's the two things that we hold ourselves to account at our forum, to say, are we actually, by doing this, actually meeting those two overarching aims? It's our real foundation, our core. So it's the thing that we keep coming back to. In the tree, you'll see that we have got some roots that kind of hold us to that as well, which is using our population health intelligence, and I'll come a bit more on that in a moment. That recognising primacy of place, not organisation, which again links into one of the other developments we're doing. Co-designing those solutions I've just talked about, and then building on what's working. And then filling the gaps, and I'll come on to that a bit more later on. You'll also, all of our plans are underpinned by taking personalised care approaches. So that's that. I'd like to, if it's possible, just to talk more about the second slide, which is I hope is a helpful one pager about the things we're doing and where it fits. So we have come to 4 priorities in our place. These have been agreed and co-designed by those at our board. Our board is very well ranging. It's a very open forum with everyone having an equal voice and absolutely make sure we seek out everybody's voices. So these are a definitely collective and collaborative set of priorities. The first one is a real foundation piece, and that's around building our community neighbourhood teams. We've got some of those in place really, I would say, quite advanced, some are less. So this is about how do we spend some concentrated effort to bring people together at a place, build those trusted relationships, enable those teams to be problem solving themselves. How do we hear that voice? And then how do we adapt some of the things we're doing to make sure that it's as seamless for people as possible? There is a huge piece of culture and behaviour in that. And it's not a one-off. It will be that iterative sessions, focus on things that they want to work on with some facilitation. But we do think that's one of our foundations. The second one is around on-the-day demand. And this has come out of the pressure that our system and across the West felt last winter. And for some of our colleagues are still feeling now, particularly in certain areas of deprivation around our primary care. And we are starting to understand better with support from our BI colleagues about that demand and where that is being met at the moment. We're also hearing from people who are saying this isn't meeting our needs. So we know that we've got a disconnect here slightly between what we've got and what people are wanting and needing. And also our services, for all we have a real richness, we feel this is a bit of a rewiring point where we might have the wrong people going to the wrong places for the wrong thing. So how do we rewire that as a collective and a collaborative place, thinking about all our assets, about how could we do that in a different way? That all won't be in place by winter for sure, but we are focusing on what could we do for winter, really thinking about those people who need continuity of care, that actually need to see somebody who knows them well, and around long-term condition management, but also those people who continuity around the thing they need some help with doesn't need that continuity, and could we see them in a on the day way that meets their need, doesn't escalate care into more secondary options, but actually meets that first priority about keeping people at place. There is a proposal, Chair, to bring a paper in September with costed options around some of that. We are first looking at what have we got already, what could we rewire, not looking to come with a big bucket looking for some money. So I just want to say that we are really looking at what our assets are already. The third part we're looking at is the intermediate care strategy, and the discussions to date are saying if we could get our first piece around our neighbourhood teams working in a seamless way around people, with the aim to keep them in their place as our priority, and if we start to rewire the on the day, we think that will make very big inroads into that intermediate care strategy delivery at place. It will also look to, if we realign what we're doing, how does that give our practitioners headspace to really look at that prevention agenda? And if we look at our health inequalities and our areas of deprivation, we absolutely know that we need to focus on that, because otherwise we're not being able to manage the demand that's coming through, and we're not doing the right thing for people. So those are the two bits that fit together there. The fourth area is really looking around those areas of health inequity, and you'll see in the paper our public health colleagues, so thank you Rachel to your team who've been amazing, really that stark point of we have women and men dying 8 to 6 years earlier because of where they live, where we have people within a couple of streets or half a mile ago whose life expectancy is a lot longer. So we are really focusing on those areas, and that's the health inequality work that we are starting. We're not as far on as Central, I'm going to be very honest. I think we're a little bit behind, but we are learning from what Central are doing, which I think will accelerating, and working very closely with our voluntary sector and community enterprises and community groups, building on what's already there, not looking to helicopter and bring additional services in. We also, at this point, I would say, I don't think we know what would make a difference for people, so we're trying to keep that really open mind. We suspect it may not always be the health problem that is the first thing in those individuals' minds. So how do we have a very wide conversation around health and well-being, and what would that look like as a solution? Some of underlying principles, I think co-designing with people, we've already talked about that from Lucy's paper, is absolutely a key principle. Embedding that personalised care approach all the way through. Delayering and simplifying. We spend a lot of time going, if we press the simplify button, what would that look like? We live in a complex and complicated world. How do we make it simple for our practitioners, but also for our citizens? How do we make it as easy as possible to find the right support? And that is a challenge, I think, for us as a collective. How do we keep things and not layer things in? But particularly we look at, if a service or support area is not working, how do we have that conversation to say that's not working? How do we adapt it rather than bring something in on top? Thank you, John. Thank you for the nudge. The intelligence piece, I think, is really key for us, and Paul has put together a really good slide around some of that, how that business intelligence is coming together. And we're using a quality improvement, so we're not looking at any of what we're doing as pilots. They are work that we will iteratively learn and build and learn and build. Triple outcomes, really important for us. That goes down to, how do we improve people's health and well-being, and how do we know? How do we hear about people's experience of care? That's not only our citizens and the people that care for them and their families, but also our staff. That also links back to Lucy's report about how do we know? And then how do we look at how we are, I don't like the word optimising resources, but using our resources wisely, I would rather put. All of those are aligned and link back to both our place priorities, our system priorities, and our national priorities. So we have got golden threads that all link back. So things like our long-term plan, the fuller stock take, Hewitt, Core 20+5, all of the things we're seeing how they link back and deliver other priorities, but still keep us true to the things that we said we were going to do at place. The BI point is important. We have got lots of, I would say we have lots of data. We're not always very good at taking that forward to intelligence. So I think this is a piece of work that's been really key. And again, really big thank you to our partners who are embracing it as well with us, to say, how do we add that? So we have a true picture of demand at place and what is happening, not just looking at one point of the lens. So that's really important. All work in progress, I have to say, and it is building day on day. I think the rest of it is probably quite self-explanatory, and the slides really do show those areas of deprivation. And we're able now to start to look at people's journeys about how they're accessing services, and the plan is to have that data available for our neighbourhood teams so they can see on a run chart, how are we doing using the triple aim data, what's going right, what's going maybe not so right, how do we address it? We would then to aggregate that at a PCN level and then aggregate it again at an ICA level, which gives us, so what, and are we measuring what we said we were going to do? I think I'm going to stop
Perfect.
there.
Thank you very much. Very thorough. Thank you. Questions? Rachel?
Thanks, Julia. I'd be really interested in talking to you a bit more about the neighbourhood teams as well, just because if you've got some kind of inaction, and then particularly the kind of the link through the PCNs, but also the wider neighbourhood team and how it's working. I'm just interested in also one of the underpinning principles, but also how the anchor institution piece is playing through into employment, the wider determinants of health, and whether that's feeding through into this work as an enabler. So it's also recognising that role of health within your sort of subsystem.
I think I understand the question, Rachel.
Right.
Yeah.
I think in terms of the anchor institution, the heavy lifting needs to be done by the ICB, and the impacts will be in place. So I don't think we've made as much progress on that as we might have done in our first year. But there is the health and work initiative that's coming out now with DWP that we will want to be part of. So and again, going back to the Marmot review, the educational attainment of children and their ability to have meaningful jobs as they grow older. If you look at the stats that Juliet's got in here around the average age of literacy in some parts of the west of Cornwall, that needs to be a real targeted place for us to be working with the local authority through the integrated care partnership. So I think it's something that we'll grow into in our second year. But what I wanted to say about what Juliet's got in front of us today is that the feedback that I've had from some ICB colleagues is you're being very brave in taking a bottom-up approach to place development. I think the growing maturity of our ICAs is starting to tell us that that was that wasn't really brave, it was sensible. So if I look at the I want to say urgent, but you don't like me using that word, Juliet, the unmet need on the day, there is a really strong picture there that shows that we're starting to understand the needs of our people that we didn't before, which is a brilliant segue into doing something about it. So I take the anchor institution point that we'll pick that up, but from an ICA is great, thank you.
So we're going to take Carol, Patrick, then we're going to try and wrap this up and summarise and get to some conclusions. Carol.
Thanks, Julia. Really good presentation, and I think the diagrams really explain the strategy and the sense of direction. I just wanted to bring it back down to a personal experience, actually, in that question, and you already said it, which is how do people, and I say people rather than the patient, because I'm not the patient in my personal experience, but we sort of fell into a really good experience of the care that my dad is receiving at home. And I'm someone that sort of knows where I might be going, even though I don't know what I'm asking for. And I think that's really important that we, often I don't think it's that perhaps there's a fear that we think the queue will be quite long if we give people, this is what could happen. Because actually for me, I think actually we were able to help the system and saying, actually, we don't need that. We don't need that. Actually, what you've delivered is fantastic now. We're getting really good care at home. So I think the knowing where to go, what to ask is a really key point as soon as we start doing that. Because even though I sort of understand this isn't my background, I still, looking at that, wouldn't really know what I would be doing. And I would probably think it didn't apply to me and my father, who's not got any critical long-term conditions. He's just older and needs a bit of care at home occasionally.
Thank you for that. Patrick?
Thanks. A question and an offer, if I may. This feels really impressive work, and it looks to me like this is the hard yards of those different care model development, pushing it every single day. I wondered if there's a cost model around the measures of effectiveness, and I'm coming at it from in a former life developing community programs where we ended up boiling it down to every £1 we spent on this type of work avoided £4 of cost in primary, secondary, tertiary interventions, and that became really powerful. It's a business proposition as much as a care one. So I wondered if that's being worked on, and if not, my offer is to help with developing a method if we can.
So you've raised this before. I just want to pick up on that point before I get to Neil and to Kate. There's something about separating value of activity from accounting for money, and I don't think we do a lot of the accounting bit. Maybe we just got to upgrade a bit more the way in which we look to do value analysis. But Neil, you go next.
So I just wanted to make a point around the other important outcome of system and partner stability. I think that the approach of working in teams and sharing things. So I had the privilege of being at the West ICA on the day, development day. And if you look at the trees, a lot of you will know that in a wood and a forest, it's not just the roots of the tree, it's the interconnectedness in which trees can nourish other trees when they're problem. That was exhibited in that meeting through the health inequality understanding that's even within West Cornwall there are areas where people are struggling and need a bit of help, and partners and colleagues understand that and now understand why that is. So that's about data informing you and I will say empowering the right approaches in the right places and not punishing people. There is a national forum on commissioning at place, and the first papers from the first meeting came out recently. On every one of the, it was a good summary, it was 4 pages. On every one of the 4 pages, the point was made that this is the right thing to do, but it's hard and it will take time. And I think we need to understand that, because what we need to see from this approach is a sustainable approach that helps people, and I think will help staff and help keep staff working together.
Very good, thank you. So if I can just make a couple of observations, Juliet, if that's okay, and I'm going to look at Kate first of all. There's something about some of the stakeholder feedback that we've had about primary care networks, understanding what we're doing. And of course, we work through our ICAs, but I do think there's a piece of work to understand the primary care networks and how they get to see what we're doing. And I'm sure they're engaged with you, but there is some wider messaging that is to the whole. I think we just need to pick that up and think about how we do that. So are you happy for me to move to the recommendations?
Can I just make a couple of points, if that's okay? Let's pick the ICB bit up. So when we did the stakeholder survey, I don't think some of our PCNs realise that ICAs are part of the ICB. And almost it doesn't matter, except when they say, we don't talk to us and you're not doing anything, then that does matter, because we're not doing it. We've decided a bottom-up approach is what we'll do. So I think we need to try and to square that circle over the next year. The bit I did want to pick up was the value in the accounting bit, because I actually think we can do the value analysis and it can have a massive impact on our accounting. So just the impact of personal health budgets, we know from some regional public health work that's been done who our at-risk populations are for acute respiratory admission this winter. We know where they live, and we also know what will make it better. A bit more disposable income so you can put the heating on. That could be a personal health budget. And the more we get to know about the segments of our population who need a bit of something to keep them well, then we can make proper strategic financial decisions that will have a value impact for the person and an accounting impact for the system. I just want to finish a note. I'm going on. But because
a helpful one, but there you go.
Later on today, we will be talking about whether we need more acute hospital beds. Now, we know that the impact for the people who are perhaps frail and elderly going into those beds isn't the greatest, and we probably know that there are alternatives. It is probably the most expensive measure we could take this winter. So as we're moving into winter, with places developing in this way, acknowledging Neil's point around it will take a long time to get to a point that we'd like to be at, we are going to have to take some strategic financial risks about how we back what people know about places and what we put in place to manage demand, so that we don't cause more harm this winter. We have more people having a better time than they would have done. So this gives me hope that we could get to that place. Thank you.
Yeah, thank you. And Juliet, you know, I wrote to you a bit prior today, having seen your paper, to say thank you. What a wonderful paper it was to you and your colleagues, because there were some other colleagues of yours which you wanted to celebrate. Paul, I forget his surname. Yeah, Abraham. Pass on our thanks to him as well, and to all your wider colleagues. So let's go through the recommendations. I think everyone is delighted to read the paper and the way you so well articulated what you wanted to do in the direction of travel. I think everyone is supporting and noting that. Yes? Yeah? I guess I just wanted to tease out a little bit more recommendation too, in terms of the support and need for the continued BI intelligent input. I'm going to look to you, Kate, to answer that one. How does that manifest itself?
We will meet your need.
Oh, there we go. We can minute that one. We can meet the need. Excellent.
Well, we're going to have to, aren't we?
The only challenge I've got then as item 3 is we did talk earlier on about how absolutely chocker September's going to be. So I think there's 2 types of things, Kate, you might want to think about. Either can it wait until October, or if not, I think we need to empower you. Well, you can do it anyway, but I think you need our support to be able to say, do what is necessary to support this direction of travel before we get back to. Does that work for you?
Yeah, because we'll be talking about winter in September. And
yeah,
exactly. Proposals for winter. Yeah. So it absolutely needs
so is the board happy to take that as we're empowering Kate to work on our collective's behalf rather than wait for September, October for another paper? Does that work for everyone? Yep. Over to you. And thank you. Well done to you and your colleagues. Thank you. Okay.
And you should note, John, no pilots in the West.
Very good. Very good. Very good. Okay. So where are we? We're moving on to Susan, CQC self-assessment update, please.
The paper, I have to make an apology. We had a late addendum to the paper, which was following a meeting that Kate had been to with CQC Chief Executive. So we've attached the slides for folk, but I've put some fairly helpful links into the paper just if you want further reading. This is the second time we've brought a paper back on the CQC, and as you know, they've got a new regulatory model with an overall aim and focus on tackling inequalities and driving in improvement, with a greater focus on care across local areas and systems. And we were really clear the last time I presented that this work is being done in partnership with our local authority. However, as you'll go through the paper, it's very clear there are elements within the CQC inspection process that are very specific to the local authority and very specific to health. However, there's a great deal of overlap. So currently our responsible officers, which are Emma Trethewey for the local authority and Nikki Thomas for the ICB, are meeting on a fortnightly basis to bring all of those similarities together. However, we are having a working group for health, particularly to gather all of the evidence. So what the paper sets out really to do is to talk about the CQ assessment process, the difference between the ICS and the local authority, the process that we go through, and there's a little bit in 4.4 around ICS preparedness and timetables, just to help us really think about what it is we need to do. However, I don't think we can underestimate the amount of work that this is going to take. And one of the things I have taken the liberty just to put into the paper as well, Chair, is the work that the CQC did around the summer in 2022, where they did a coordinated inspection of 10 ICSs, particularly looking at urgent and emergency care pathways, because we know through this board as well just how much concern that we've had around potential harm, whether it's waiting in an ED department, whether it's ambulances queuing and not meeting their CAT2 mean times. So I think it's a really good piece of work for us as well. And I was talking to Kate Maynard about how we take the work we're doing around SOF, the System Oversight Framework, and Tier 1 for our urgency emergency pathways against the CQC work that was done. They held a huge workshop in London in May 2022 and went through all of the actions that they felt were needed around urgent and emergency. So not only is it helpful for us in directing where we need to focus on for a CQC inspection, but also I think it's a really helpful checklist against the actions that we're taking to get us away from SOF 4. We're not in SOF 4, out of SOF 3 into SOF 2, but also to take us out of Tier 1 for the future. But overall, this is about the safety of our population.
Right.
So I'm happy to take any questions.
Excellent paper, Susan, if I may say. Debbie.
Yes, so thank you, Susan. And it was an excellent presentation that was given to the South West Region Chief Execs by Sean O'Kelly. It really was very helpful. It brought it absolutely to life. And I think this is one of the areas where collaborating as part of a system is really going to help us enormously. So provider organisations, including primary care, will still continue with their own regulatory compliance and requirements, but there are things other than urgent and emergency care that we could be rightfully looking at. So if I'm looking now at our current level of performance and performance risk that we're carrying in the system, we are under significant acute pressure with demand for mental health. And the CQC, given our recent inspection, will quite rightly probably be looking at us as a system in terms of what are we doing together, applying the methodology that we know was applied to us on the broader UEC. Could we use this as a lens to actually review our current position with urgent emergency with mental health care? So we'd be really happy to work with you, almost in doing a sort of trial run self-assessment or something along those lines.
No, fantastic. And please don't think that the sole focus will be UEC. It's there as an example of what CQC are looking at, but absolutely. And I've already, Kim and I are talking regularly on this. So no, thank you, Debbie.
Okay, so no other questions. So I have to say, I think the reading again the people first summary towards the back end and what they're covering, is it your intention to take each of those bullet points at some point and articulate how you think we're doing against those?
It all blends beautifully, Chair, with the work that we're doing around the soft metrics, tier metrics, and also the ministerial action. So it all brings it all together. But I think this is a really helpful checklist for us as well, going into a CQC inspection, just to make sure that we are working through all of it.
When we come on to the work that Kate Maynard's doing,
yes,
you'll do the golden thread between you all to make sure it is all
Absolutely.
linking together. That's really assuring. So shall we move to the recommend? Oh, Rachel.
Just a comment really to say that, the local authority assurance framework, CQC assessments, also at the same time going on. And I'm glad that Emma Trethewey is the key link into the council, who also has oversight of that process, and obviously a joint approach. And I also sort of would recommend, I guess, a review of something like the SEND joint inspection to see if there's any learning around how that was conducted and preparation for that. And I see from your nodding that is in mind. So that's great. Thanks.
Thanks, Rachel.
Recommendations, just looking around, no more comments, great. So we're going to note the content of the paper, note the internal self-assessment against the people first approach. When do you think we might get some sense, just roughly what quarter are we talking about getting some feedback in?
An update to one of the autumn boards, bearing in mind you've said September's busy.
Yeah, so autumn, that's why I went for a quarter, really. Thank you for that. If everyone's happy with that. And then item 3, receive via the ICB Quality and Pathways of Care Committee a review back in the autumn board. Very good. Everybody happy with those 3? Yeah. Approved. Thank you very much. Well done, Susan, on that paper. Tough subject to communicate quickly. You've done a good job there. So let's move on to the next item. Check in my agenda, which is, Kate, you're going to have to help us with the Civic Universities Agreement, please.
Yes, thank you. So the Civic Universities Agreement has been developed by RCHT, the local authority, and Falmouth and Exeter universities, and it's in response to work that took place in 2018-19 around what role universities can play in civic society. The work predates the development of the Integrated Care Board, and RCHT, I think, have already signed the Civic Universities Agreement. So it's with us today so that for Cornwall and the Isles of Scilly ICB, that we sign the Civic Agreement alongside our partners across our provider organisations, to reflect that we want to work with our universities to make sure we maximise civic value for our people, and that the way we are working around research and innovation means that we provide a better place to grow up, to live and to grow old in Cornwall and the Isles of Scilly. And I think that's all I want to say.
Good, thank you. So I think we could, Debbie?
Yeah, could we just note that we're also part of collaboration with the universities in this.
I didn't hear you. Can you say that again?
Could we note that it's not just RCHT and CFT is also working in collaboration in this space?
Is it specifically around the Civic University Agreement? Because yeah, perfect.
Yeah, and on joint research and collaboration around roles development.
Absolutely endorse that point, Debbie. Thank you for making it. You've taken words out of my mouth. The other thing I wanted to say was, and Ella, you might know this much better than me, but in my fairly limited experience of this, I think we've got to be quite proactive in this, in actually you're smiling at me, but in identifying things that would be really useful and then working collaboratively, because otherwise I think it has been a little bit piecemeal with not for any wrong reason, just because we haven't been proactive in coordinating. And so I think if we use our research and development teams to be sure we're doing that. But Ella, are you able to comment any more than that?
I just completely agree with that. I think it's really important we're specific around what we want to do as soon as possible, and you know, like you say, be the proactive partners.
So we're building a specific focus around research, innovation and improvement as part of our proposed consultation for restructuring. And we also have our membership of the Academic Health Science Network, which is trying to pull all of this together into one place. So we're maximising the input of the universities, but that is targeted at the priorities that we've set as an NHS and a care system for Cornwall and the Isles of Scilly. And when John Siddle comes later this afternoon, you'll be able to see the live demonstration of that.
Okay, so shall we move to the recommendations? Okay, so I'm not going to read them out. You've had a chance to read them. Recommendation 1 and recommendation 2 is basically to support this agreement, for which I think we can say yes to. Yes. Thank you. So Rachel, if I can just ask for you to pass on my thanks to Linda and to Kate Canali. Rachel. Sorry. To you. Sorry, no.
There's still two Rachel.
Oh, yes, of course. Yeah, yes. We're declining on the Rachel front and growing on the Kate front. So okay. If you could pass on my thanks, because this came up at the Cornwall Leadership Board, and as we're all working out the new ways of working and that kind of thing, I had to say, can it come through here? But we're catching up on that. So I wanted to reach out and say thank you to Linda and to Kate. So please pass on my thanks, and delighted we can sign it off. And of course, you'll let Ali know as well. So thank you, Rachel, for doing that. Okay, so where are we? Oh my gosh, it's 11:40. That means coffee. Thank you, everyone. So let's break for a moment and see you at 11:50. Thank you very much.
Thank you.
Okay, everyone, let's go. Thank you very much. Sorry about being a few minutes late. Note to self, with 25 people in the room and a coffee machine that's in high demand, it can't work at the pace that the demand is there. So there we are, supply and demand. Okay, so we'll move on to the next item, which is committee chairs and partner member updates. So we've got two non-execs who aren't here, which is Sanj and Han. I don't believe there's anything, unless anyone wants to raise anything on theirs.
Yeah, I was going to ask you that. Just light touch on what you want.
Yeah, Patrick.
In Tarn's absence, so I have written this report. She was at the committee at which we had this discussion. Just wanted to highlight that we received a presentation from Paul Hargreaves on behalf of both trusts relating to the agency costs issue and workforce efficiency. That's elsewhere on the agenda for today, but a good conversation, and we're following up at the next meetings as well, but just highlighting that.
As we can to answer any other challenges we've got on those two areas, but no, if not, we'll move on to Martin. Martin, anything from you?
Not really, John. Our most recent audit committee was relating mainly to the accounts, which came to the board we've already had. So we
okay. Thank you very much, Carol.
Nothing to add to the paper, Chair, just to say that we're still working around the timings of the integrated performance report to make sure that that's coming to committee in a timely way.
And there'll be some changes in there too. So Neil?
For the ICA committee, a big thanks to Juliet, because much of what I put in that chair's report is picked up there. But I think the difference is that when I'm writing, I've been writing the ICAs, because much of what is going on across all three ICAs. And I just wanted to pick up at the end of my report a statement that I made. The board are asked to note and support the above and be mindful of the intent to see 1% of the ICB budget. When I first wrote it, I had to draw it back quickly. I actually wrote 12 million. That must be wishful thinking. Would be invested in schemes that deliver on prevention as we move towards 24-25. 1.2 million in the big scheme of things is only 1%, but it is really important, I think, to think about prevention. And on the PCC Primary Care Committee, I just wanted to highlight that ICB has delegated authority to the PCC to assure against the plan for recovery and access. That's well in hand and was discussed in some detail 2 days ago, and a summary will be presented to the PCC during Q3, I think possibly October, with it's with an intent to bring it back to board the next month. It's either September to October, which sounds more likely now, in terms of progress against the recovery and access plan for primary care.
Very good. Yep.
And Neil, you're right, it's 12 million, it isn't 1.2. 1% of our budget's 12 million.
Lovely. So I can revise
beautifully.
that.
You knew. Come on, you knew. You just wanted us to say it. Okay.
Thank you.
Wigglesworth was doing some work around defining how we'd measure the diversion of money into preventative work, which she may not have done yet, but would be really helpful for us to track that we are putting money into prevention. I spoke to Emma Rouse yesterday, and the £3 million we've put into the voluntary sector, she says, from a regional voluntary sector feedback perspective, is massive because other places haven't. So we need to carry on doing that so that we can do what we said we were going to do.
Thank you. I stand corrected.
Oh, very good.
gratefully.
Thank you very much. Okay, so that's the non-execs. I think I've covered off. So let's move to the partner members first of all. So I'll just go around the table as I can see. So as Ali's not here, Rachel, is there anything that you would like to say on Ali's section?
No, nothing.
Lovely. Thank you very much. Debbie?
No, other than to just test with colleagues really that trying to bring some innovative themes through the mental health partner update is actually of value to the board. It's just that we're trying to seek out things that perhaps colleagues might not read or hear about from mental health, learning disabilities and autism, and I just wanted to test that they are of value because
Feedback, colleagues? Lots of nodding and thumbs. Yes, please.
So certainly from a research perspective, this is something that also would be of interest to the ICB, and we were able to showcase some of this work at the Royal Court. So if people are interested, these are the sorts of things that we welcome support with.
Yeah, very good. Thank you very much. Mary?
John, yeah, could I just say I really welcome that because I know we all try really hard to get equity across everything that we're all doing, but I do think maybe we can hear more about mental health than we do, and so something like that is really helpful just so that we do get a focus on there are things going on.
And of course, you know what the next agenda item is. It's the deep dive into mental health. So you set it up beautifully. Thank you. Thank you so much. We designed that between you and I, didn't we? Excellent. Anything else, Debbie?
Not from my...
Any questions for Debbie, anyone?
No.
Can I just come in? So Debbie, I just noticed there is actually under section 3 for noting, very opportunity based focus for me really in terms of key risks for the ICB from a partner member perspective. So I think looking into the future, this is where we would put any risks that the partner would like to escalate or bring to attention of ICB board's attention.
Great point. Okay.
In which case, I would like to comment on the NHS partner update.
We'll get there when it's absolutely.
Thank you.
Feel free to say as read, but would you like to comment on Steve's paper?
Well, I'd just like to note, I think as we did it earlier, but just build on that a little bit around appreciating and to some extent celebrating the improvements we've seen around the ambulance handovers and the delayed transfers. However, also acknowledging for Q2, there is a kind of monumental challenge ahead of us still, and we really need to keep focused on that. But the rest of the report, I think, can be taken as read. Thank you.
Debbie, this is your moment.
No. So I think for the first time, this feels as if, and Marion knows my view, that feels more like this is an RCHT report rather than an NHS partner update report, which I think is the role of it. Now I know Steve's on leave, so I think I'm making that just as an observation rather than a criticism. So please take it in that spirit. However, the reason why I feel so passionately about that is because mental health has been under Opal 4 and under extreme pressure for the last 2 months. And I would like us to really demonstrate that we have as much commitment together as a system on addressing the underlying factors that drive urgent and emergency care and increased acuity and demand for mental health as we do for physical health. So I know outside this room there is support from colleagues for that, but I do believe at system level we have a way to go to demonstrate parity of curiosity when we're under extreme pressure.
So I think that's a good point and it's well made, and we'll certainly continue the discussions about how we have a provider representative who's also a representative of one provider, and we may need to just think about how we do that slightly differently, but we'll certainly take the message back, Deb, and it's well heard.
So we also need to, so SWAST's a provider, so and I think we started off quite well trying to make sure we had a rounded view. UHP, we had a board to board with them recently, and they would very much like their similar but different pressures to be fed in, as well as their successors. And then of course we've got primary care, so Andy's here representing primary care, but we also have an emerging primary care collaborative that probably we need that collaborative more formally plugged into our provider arrangements. So we'll pick that up, and in September perhaps we could bring back a plan.
Yeah, absolutely. I'll feed that back and with Steve think about how we improve that going forward.
So I think it's Steve and Will and Debbie and Anne and it needs to be a much wider group. So I'll take an action to talk to Steve and then look at how we pull all of that together.
Martin?
Yeah, I just wanted to mention that first of all, the UHP, the Plymouth visit was great. I think it did, for me, was a real eye-opener into how much of our population uses that side of the border, if you like, and how important it is to us. I think Steve actually does quite a good job at trying to bring some of that when he gets support. Second point was just on the mental health one. I think we are probably slightly guilty, even in the place discussions, focusing on prevention to secondary care. But I'm obviously convinced that the work being done at community level, has an equally valid and large impact on some of the urgent mental health issues that the community face. So I guess we perhaps just need to make sure we consciously note that and highlight it when we can, and make sure it is having that.
So one of the things that Kate and I want to do as we go through the consultation period also is to think about as we go through both that and the review of the of the committees that we're doing and that kind of thing, is to quite look as to whether there are any nuances as to who's in the room or needs to change on some of that, because it was great for July last year, but is there somebody who should be in the room, either an attendee or in a different way, that we've got to do from that? So I think there are some, taking Neil on, you said something earlier on about an honest appraisal of what can we say, what we really feel in a open kind of way. We need to do that here too, because if we've got the right people in the room, we can move forward. If we haven't, then it's going to always hold us back.
Yeah, Emma Ridgewell-Howard's got.
Yeah, Emma.
Yeah, I can't. Thanks, John. It's just to add on exactly that point. One or two colleagues who are obviously missing include LPC colleagues, for instance. I think as we're sort of moving forward, I had a meeting with them regularly. Had one yesterday, and I think that's an important point. They and others to look to be perhaps attendees in the same way that the LMC is fortunate enough to be here.
Yeah.
So I had a conversation with the chair of the local community pharmacists, and I've forgotten his name. His first name is Nick. I can't remember his name. Nick Kay. So I have asked Nick if he would be prepared to come and talk to the board at some point in the autumn about the work that they're doing and how that feeds into our strengthening out of hospital services, because there's an innovation that's taking place around their work at the moment that we need to be cited on. So it's a good point both with that, and we know that there are innovations coming through our dental providers, so we could maybe do a bit of a focus towards the back end of this year on primary care in its broadest sense, not just GPs but also pharmacy, dental and our other primary care teams.
Very good, thank you. Andy?
Just to build on that, so the conversation we've just had about the NHS provider partner representative update, probably I need to self-reflect on how I continue to grow the representation of pharmacy, optometry and dentistry, and the complexity of the provider landscape. We have 55 general medical providers, we have 40 odd general dental providers, and I'm afraid I don't have the figures to hand of how many optometry and providers we have. So I'd really value, maybe could we do a linked piece of work as to how we get the primary care partner.
Yeah, so that's another good example is, although Jane from Devon is here, there's something about the new Peninsula arrangements that we're chatting about that might come through also. So there's something about just a refresh of everything, and is it fit for purpose going forward? Does that work for you?
Yeah, perfect.
Yeah. Okay. Where were we? So that was, Andy, anything you want to add?
That was going to be one of the things I was going to say. So otherwise, take my paper as read. But I probably did just want to doubly highlight the GPAS data that I've supplied here. In my time as primary care partner member, this GPAS data reflects the busiest week recorded through general medical practice. And the paragraph underneath the GPAS data talks about the continued run rate and estimated 6 million contacts. 11 times per year for each member of the population, and that's increased 3.5-fold in the last 20 years and is on a steep upwards trajectory.
Which plays back to Juliet's discussion around how wider teams can support care in communities rather than general practice. It's a much broader team game.
And that voice needs to be heard loud and in here. So we've got to collect that. Okay, so I know that Emma isn't here to be able to do the voluntary sector. So I think we'll move on, if that's all right, from this section. Everybody happy to move on? Yeah? Okay, so Debbie, just tell me, are we expecting Mel physically here?
We are expecting Mel physically here.
Would you like me to move things back?
If you could take item 16 first, and then it may be that I need to start as a single act rather than a double act.
No, tell what I'm happy to do.
Absolutely
There are
on
other
her way.
parts of the agenda I'm more than happy to bring forward, because I think, you know, it's important that she's here. So, yeah, go on.
So Nick isn't here yet.
No, that's why I'm saying I was just going to jump over that. So, in fact, I'm going to jump with everyone's support, and we'll wait for Mel to arrive. Nick isn't here because he's got a pre-meeting and won't be with us until 1 o'clock-ish. Therefore, it's John Sindel, I guess, is joining us after lunch as well, so he's not here. So, this is how you fast-track to Chris's paper. I'm sure you've prepared for this moment, Chris. I'll give you 30 seconds to get your papers together. Okay. If what we could do is jump to a discussion around pharmacy, ophthalmology, and dentistry update, item 20. Chris, please.
So I'll take the paper as read, but just to highlight some key points and maybe then open it up for a discussion. Really, this is to give a summary of pharmacy, optometry, and dental, putting it in the context that as part of the recovering core services, a priority for the NHS was to recover dental activity. And then from the 1st of April this year, commissioning of dental, optometry and community pharmacy is now under the ICB. But the day-to-day management is being handled by a CCH, a collaborative commissioning hub, which is for the Southwest region, currently housed in Somerset. And so I think there's been a lot of work going on between in our primary care team to understand the roles and responsibilities between the CCH and the ICB. And also there's been work going on across the peninsula in setting up joint dental operational groups and joint community pharmacy groups as well. But if I just focus on dentistry, the challenges, I think everyone's aware of the challenge of getting access to dental care. There's 40,000 people on the waiting list in Cornwall alone, and so the ICB, in conjunction with the CCG, has been working to try and see how much we can flex the national contract, and so there's been a lot of work going on to try and have a more novel way to access, in essence, unmet need. Targeting our dental care to specific populations, children, those with other comorbidities and deprivation, and that's an exciting piece of work which is underway, and hopefully, if successful in a practice that we're about to start that program, we could be able to roll it out with scale. And it's just mindful of the fact that it's dental care is no different to any other aspect of health, that in the most deprived areas it's the hardest to get access to your dentistry, and they have the worst dental health outcomes, which has a knock-on effect on their sort of general health as well. So workforce remains an issue. I can touch on community pharmacy again, that they are doing a lot of work to try and take the burden off general practice. And we've already had services running in that context, weekend out of hours services, which we believe have stopped 300 people ending up in ED otherwise. But there's launching pharmacy first, and so pharmacists will be able to prescribe some medication for 7 core ailments. So Yeah, I'll open it up to questions, but I think the key issue that we're working on is around sort of flexing the dental contract.
Can I just augment the community pharmacy, because I spoke to Nick Kay yesterday, and he's the Chief Exec of Community Pharmacy Cornwall and Chair of the National Pharmacy Association. He is an attendee at the NHS Recovery Summit. He went last week, and Cornwall's in a really great position to be able to do the extended role of community pharmacists, and he's really keen that we use the strength that we've got in community pharmacy in Cornwall to be able to offer the best advances around implementing the fuller review. So it would be great to make sure that we've got that fully captured, and I just wanted to read his text so that I could make sure that I reflected our conversation fully.
Chris, you mentioned about recruitment. Are you tracking the closure of pharmacies? Because I know of a couple that are starting to put signs up saying we will be closing.
I'm aware of
Yeah.
community pharmacies closing. I couldn't give you any.
I mean, it's one thing being able to dispense, but if you can't get to a pharmacist.
Yeah.
Rachel?
Can I just say, so one of the duties of the local authorities to do a pharmaceutical needs assessment, so all the applications and assessment of need against pharmacies either opening or closing would be captured through that, working with ICB pharmacy lead as well, so that information is captured through that process.
But the point's well made, so we need to look at how we can stabilise community pharmacy, because they are going to be such a large part of modernising primary care. I get my nomenclature wrong. Modernising primary care in our community. So we'll pick that up, Rachel and Carol.
Rachel, keep going.
A further sort of point around both dental and pharmacies, with some of the investment to the council in the 256 grants, we're in the process of setting up some additional services that are around preventative work for both oral health, so focusing on children, older adults and people with special educational needs, so around the brushing element, and also the pharmacies that are in particular areas of deprivation, some engaged work around identifying needs of people that are coming in regularly, whether it's drug and alcohol, mental health problems, and engaging in particular health promotion activities with those groups as well. So there's some preventative work that we're doing in Cornwall, which is quite innovative. That's under work with the LPC. Nick would know about it, but just wanted to highlight for the board's sort of attention that that's our attempt to, obviously work alongside the general contracting of primary care services.
Rachel, and then Debbie.
Yeah, I think it was just to also acknowledge that this is where the ICS can be part of a wider working across the region. So there's some fantastic work going on locally, actually, some really exciting work, both in pharmacy and dentistry. But I think there's also playing into some of the bigger pieces, things like training hubs, etc., where in order to retain and recruit both pharmacists and dentists for the future, that I just encourage the ICB to think about as well, but both in terms of that and its local work.
So I feel like I'm being a bit vocal today, John. Apologies for that. But so I'd just like to. It's great to hear the work, and I absolutely hear the ambition, and we all know the scale of the challenge, particularly around dental, and how many people at the present moment just can't access a dentist. And actually, what's really hard is that probably most of us have given up trying to access an NHS dentist because we can afford to pay. But there are lots of people out there who really can't, and the impact not only on ongoing pain, the impact on their physical health, but also their emotional and mental health, and even their standing in their communities is significantly impacted by the absence of good quality dental care. And I know this is going to take us a long time to fix, but if we were ever going to try and fix something using a health inequalities approach, surely in our fixing of this, we have to put addressing the care for those that need it the most, who we might not be hearing most from at the centre of any of our plans.
We're going to go to Emma first, and then Chris, and then Mary.
Thanks, John. Just a really practical note for board awareness that those who don't know, the primary care operations group actually collects the contract variation, including closures for pharmacy on a regular basis. So that is seen and tracked as well. Just coming back to the previous point that was made around tracking that.
Thank you, Chris.
Just to reflect on Debbie's point, so the NHS has never funded dental care for 100% of the population. It's only funded for about 50%, and so therefore I think it's really important on the fact that the ICB has the authority, has got the commissioning authority to do exactly what you've just said, and so this sort of flexing in the contract is specifically to target those most in need of the dental care with an equity lens, noting that the funding will never reach, and never has done, 100% of the population, unlike the statutory access to provide a GP.
Thanks for clarification.
Yeah. Harry?
Thank you. It's just adding to that, really, that we've had some quite exciting conversations as a board about how we might continue to be more innovative in how we spend money. But I just think we do need to focus on people with intellectual disabilities and others for their quality of life as well as their standing in communities, but because they don't tend to speak very loudly. And if they do become urgent, their needs are much greater. And so we've got anaesthetics and all sorts of things going on which we wouldn't otherwise. So I think there's a really powerful argument for as a board us focusing on that.
Rachel, may I ask you to reflect on the conversation we had? As you know, we've been chatting with some of our members of Parliament and some colleagues about quite what we might do, because there's something about taking there isn't enough money. Having said that, there has been an underspend in the money that is available. So it's not like, even if you had the money, my point is trying to be, is that we can't use it. So, and taking Mary's point, there's something about not just vulnerable people, but particularly children. If we had to go first somewhere. So is there anything you'd like to just summarise from maybe the kind of conversation we've been having with yourself about where we might be going on this? Yeah.
I wouldn't want to cut across Rachel. Of the 40,000, this includes children, and for me this is the bit where I get most uncomfortable, because we know that there are children who haven't seen a dentist since before COVID, and I regularly saw letters of people who had children who were 11 and hadn't seen a dentist. So there's some fundamental thing about prevention, going back to our discussion. I think that we should, and I'd like to do this on a regional basis, but you could do it on a local basis, and maybe given what Chris has said about dealing with at a very local level, maybe that's the best place to start, about whether you could secure through contract mechanisms access for all children or children in certain groups, and do it through some sort of buying of a policy. I don't know. That was where we'd got to in the discussion about, does the flexibilities of the commissioning that we're pushing and pushing and pushing allow us to have that conversation, and how, and you've got to be careful about that conversation, but it would ensure that at least children at a certain level had access. If not, at one point we tried to get every child assessed once, but it's just the sheer capacity of to be able to do that.
So we also have another valuable facility in our dental school.
Yes.
So when the dental school opens up with three appointments, it gets booked really quickly. So perhaps what we should be doing is targeting the free appointments to the communities where we know the greatest need sits, so that we could have an innovative contract solution for children. We could have targeted dental access for those most at risk. And there is also in the paper, there's a proposal that when people have had emergency dental access, they then get their treatment finished, not just the emergency appointment. So then that would meet everybody's needs that are presenting an emergency. And if we just manage to do those three things as a step one, then we can potentially grow into what step two might look like. And I haven't said it yet this meeting, Rachel, but proportionate universalism is what it means, isn't it? Is that we're targeting our investment towards the people who we think will get the greatest gain. And so we need to log that that's what we're doing.
There is also a skill set shortage, to be fair, but also one of the discussion points that came out, Chris, that you might want to just take away from here is that if we worked with the councils to get into schools, there's a different type of skill set that could identify what's going on and doing things. So I'm just taking up something that Kate and I were just chatting over earlier on, is wonder whether we should be doing a deep dive. Right, Mel, come in. Just wondering whether we should be doing a deep dive, Kate, on dentistry at some point, maybe towards Christmas, ophthalmology in the new year, pharmacy in the new year. I think there's something about, trying to get a greater understanding as to what those groups of people are saying, and probably we would require somebody who is a dentist here, who is a pharmacist here, who is a whatever, because without that, it becomes our second-hand knowledge of what is really troubling them. Mary.
Thank you, and I think that's a really great idea, and I think we already know a lot about what we need in these areas, and I just wonder whether we should set ourselves a date by which we will have actioned something on this, so that we can really have an aim, whichever one it is that we feel most achievable. But I think deep dive will be valuable to best understand it, but I think we know the problem.
Yeah, so I think we'll leave it with Kate, because after the meeting with Rachel and some of the members of Parliament, I think there's a value here about what can we do quickly before the ultimate contract is changed, because if we wait for that, then not going to change. So
we also have to embrace innovation, and we're being approached by dental colleagues locally to say we want to do this and we can get dentists working in the NHS so that we can make the biggest difference at the time when it's needed the most. So I think we need to back our professionals, experts doing expert things, bring back phase one, and then work towards what we'd like our final outcome to look like.
Okay. Very final word, and then we're going to move on.
Observation about going back to pharmacy, the challenges within the local communities, community pharmacies. Because of the drive towards digitalisation, most of the care homes are now embracing digital care planning and pharmacy because it's integrated. The pharmacies are no longer willing to insert the prescriptions for each client onto the system, which would then be picked up at the digital end at the care homes. Consequently, the meds are arriving with no administration record, which the staff are then having to themselves copy across, which is actually illegal because we're secondary dispensing, and I think it should go to the risk assessment, to the risk register.
Very much. I'm going to jump straight to the recommendations if I can, and I'm going to add one on some advice that's just been given to me. So we're going to note the contents of the report. We're going to ask for 3 separate deep dives between now and April of next year. But bring us. Thank you, Mary. You bring us who you feel is appropriate, and when we get to the forward plan in a second, Caroline, if you can help us capture how we might do that. But also, it says in the paper in the conclusion, Chris, this will be built into the overarching strategy for primary care and will be shared via PCCC at a future board meeting. And we're noting that action. Yeah.
And that will include the full implementation of the fuller review, yeah? Yeah.
And if we can capture that point too, then. Everybody happy with that? Thank you. Excellent. So let's move on. So just before I welcome Mel, which I'll do in a second, we jumped an agenda item. Nick, are you okay if we deal with your agenda item after lunch?
Yes.
Is that okay with you?
That would suit.
Oh, I'm here to please. Okay. In which case, let me introduce Mel. How lovely to see you again.
Hello, nice to see you again. And my huge apologies for
No.
being late. My sat nav clearly has a thing for Bodmin because it sent me around several times.
That's right. Such a lovely place. Go round twice before you go, and then
lovely, but
that's
the third time it
That's
gets
Cornwall
a bit
for you.
repetitive.
Okay, so welcome to you. Do you want to introduce yourself actually, because not everybody here will know you?
No, sure. So, thank you. Yeah. So, hello everyone. I'm Melanie Walker. I'm Chief Executive of Devon Partnership Trust, which is the mental health and learning disability provider for Devon. We also provide a number of regional services, and I have a lead role, therefore, in the provider collaborative, which we're going to talk about.
Okay, so we're going to hand over to you and to Debbie, of course. You're here with many hats on today. All right. But in this space, I think we're going to not only have an exciting discussion about the mental health issues here, but I think it's also going to be showcasing some of the best practice work that is going on in provider collaborative work at the moment, for which we probably don't know enough, which we hope to know much better within the hour. So over to you.
Chair. So I'm going to introduce the item. We're going to try and do a double act. So colleagues have a briefing paper in the pack, and we've also included the presentation. So we weren't proposing to actually talk to every slide in the presentation. We were rather proposing that we would pick out a few key points and highlights, and then actually take the time to then have a discussion about, one, acknowledging the success and the achievements of the provider collaboratives to date, but also then actually having more of a conversation about what else could we do in Cornwall, in the Isles of Scilly, and perhaps in the Southwest Peninsula for mental health, learning disabilities and autism. So we really welcome the opportunity, John, of having this deep dive time with the board and in public. I think it is an amazing opportunity, and we're most grateful for that. I think the other thing is that we are all learning a new language, aren't we, in different specialisms as we come together as a system. And I know certainly from feedback from colleagues, but also from people who listen in, that the language of provider collaboratives is actually pretty impenetrable. And sometimes people go, well, we just don't know what you're on about. I'm sorry, I'm cutting to the chase, John. But having been the executive director lead for provider collaboratives in Oxford Health, which covered 5 counties in the southeast, you don't just suddenly open a provider collaborative on Monday and job done, everything works smoothly. The success and achievements that you will hear about today are as a result of years of collaborative work between different providers in both statutory providers and voluntary sector and independent sector providers as well. So this has been hard won, but certainly now I think the proof of concept of provider collaboratives is well shown and the benefits are shown, and our intention here today is to try and demystify provider collaboratives and put some colour to it. So ultimately, we all know that when ICSs were set up, providers were issued with a duty to collaborate, which we welcome. And one of the key messages we want to deliver today is that one way we can further that collaboration is to build on the work that was established through these formal provider collaboratives in our community. So if you move to what is a provider collaborative slide, I'm going to hand over to Mel because she's going to share some of her wisdom about what is a provider collaborative and what does it mean for us.
Thanks, Debbie. I feel a bit set up now. You've said I'm going to offer wisdom, so I'll do my best to share information, and you can make your own judgment about wisdom. So thank you. So as Debbie said, provider collaboratives have a long history, a whole it's the way only the NHS can do, create a whole language and put a shroud of mystery over something completely unnecessarily. And quite simply, what they are providers collaborating, but moving into more formal arrangements, and that enables the money to be much closer to the delivery of care, and that is driven by partnerships of people who are experts by experience or experts by training, designing pathways, looking at the data, and then redesigning. And it really is as simple as that. However, the simple things are often sometimes also the most complicated, and in those there's really clear guidance now, which has taken quite a long time coming, but about what the principles are, and those are on the slide. So I'll just quickly touch those. So collaboration and experts by experience or training, as I've said, management of the resources, but really focusing on the improvement in quality and value for money of the limited resources we have. And that measurement of quality is clearly quantitative, so what we can count, and qualitative, what the experience is for people, and a real opportunity to advance equality within a local population, however that's defined too. So when we operate as a collaborative, and again you've got quite a lot of detail on the slide, the work of the collaborative has been of a collaborative is focused on reducing unwarranted variation in outcomes, reducing unwarranted variations in access, and I'll give you some examples in a little while, and then making sure that where specialist services are needed, they interact as seamlessly as possible with local services. And again, we'll talk a bit more about that. We have 2 examples locally. So the Regional Provider Collaborative, which I'll come on to, which is much longer standing, and I'll talk about that. And we've taken the learning from that and taken that into Devon to look at those services which would be commissioned through the CCG and now ICB budgets and some of the local authority budgets as well. And we're seeing how we learn on that difference and connect where we can. And some of those discussions have been with Debbie and her colleagues too, and we'll come on to that. At the heart of the Provider Collaborative is the Senate, and the Senate is where the experts by experience or training come together, and that's where the debates and discussions, looking at the evidence, the benchmarking data, people's experience, ideas, innovation, all gets pulled together, and those pieces of work are then worked through in a co-production way, so people working together to design safe, effective and sustainable services, making sure that we are measuring what we're doing, because we're quite good at saying we're going to do great things and designing them, but we want to be clear to what end and that we have made the impact we want to. And if not, that's okay sometimes, because we have to try things differently, but that we know what's happened as a result of our actions and then we adjust. So if I talk about the Southwest Provider Collaborative, so the Southwest Mental Health Provider Collaborative is a regional provider collaborative where the specialist commissioning budgets for regional for mental health services are all pooled across the whole of the Southwest region. And that's taken place over many years, and working with actually Pauline and her colleagues, it's been a journey, and I'm sure Pauline might want to say something. Sorry, Rachel, I beg your pardon, Rachel. Rachel, I don't know why I called you Pauline.
There's too many Rachels anyway.
I'm not thinking about any particular Pauline. Rachel, I beg your pardon. And so what we've done during that work since 2017, where we started with adult secure services, so that was medium and low secure services, was we worked on making sure people are cared for closer to home, and we know that the number of people who were placed out of region has reduced by 69%, and the total number of people who've needed inpatient care has reduced from 450 to 350. So what we found when we started the work was a significant number of people as far afield as Durham, and with very limited connection back to their home place, their home teams, their families, if they were still in contact with their families and their communities. And we know that people's outcomes are worse if that's the case. And also we have made sure that how long people are in locked care, secure care, it has reduced significantly, so roughly a 50% reduction. So the benefit of that is, for those people, it's a much better experience. They're being moved through the pathway more swiftly but appropriately, but also we can then make savings, because locked care is very, very expensive, and there is limited therapeutic value after a certain length of time. It depends on the patient. And by doing that, we have been able to release, as well as improving the experience, I'll give you a couple of anecdotes about that in a minute, as we have been able to release money into systems. Overall, that's about £10 million. I know Debbie's going to talk in a minute about the particular impact for Cornwall. And that's money that's gone into all the ICBs, so that that investment is being invested locally to strengthen local services. We've been able to address some service gaps. So there were, when we started, there was a paucity of female secure beds for women with mental illness, and also male learning disability, people with learning disability beds. So that we've been able to close the gap of resources, improve the benefit for patients, and reduce inequities in service. The scale is huge, and you've got that set out on a slide. The size of it is really important because it gives us a strength in that mix. The partnership is all those organisations that provide mental health service, NHS mental health services, I should say, for that client group. And we've expanded into perinatal care, adult eating disorders, CAMS Tier 4, and we're looking now at other areas of work, including extending into learning disability, those services that interface with the criminal justice system. But those discussions are ongoing at the moment. And historically, Dorset, just for clarity, hasn't been part of the partnership because they tended to look east for their services, but we're in discussion with them about whether they now become part of it. So it's been a significant amount of work and a huge opportunity. So I'm going to hand to Debbie now, I think, to look at the impact for Cornwall patients, just so you've got the specifics there.
So the first thing to say is that Mel is now commissioning services from CFT. And, that is one of the big differences with a provider collaborative. So the majority of CFT services are indeed commissioned by the Integrated Care Board. But the specialised commissioning budgets that had previously been held by NHS England have now been delegated to lead provider, who is the then commissioner of the partners who provide services. So Mel contracts from CFT too. And that's actually been a really important partnership. Now, when provider collaboratives were first established, there was considerable concern about one NHS provider commissioning from another, would there be power imbalances, and so on and so forth. I have to say that it really does feel as if it is a partnership, and it is because of the Senate being at the heart of it that provider collaboratives have been focused on improving quality, patient experience, but also staff development and the redesign of clinical pathways across the piece. So although ultimately provider collaboratives did have to demonstrate significant maturity before they moved from shadow form into live form, and a lot of that was around the due diligence about the money and the governance, the lived reality of those true partnerships where the power dynamic was, or the potential for the power dynamic was actually explicit and worked through from the outset, has actually stood us in good stead. And I can't claim to be a new chief executive in this system anymore now, but having worked a lot with provider collaboratives in other areas, I was really, really heartened as to actually how light touch our provider collaborative relationships are now in the Southwest, because they are efficient and effective, and it makes a really big difference. It's almost as if they're happening and nothing gets escalated, because they're actually in very large part dealing with some of our most vulnerable and high risk mental health presentations, but doing so in a way where collaboration has really reduced risk and improved quality. So you have got a slide in your pack, colleagues, that actually demonstrates the activity for residents in Cornwall and the Isles of Scilly. And I wasn't proposing to go through all of the data here, but we did want to demonstrate to you that, this is highly specialised care. It isn't just a tiny bit of care, and there's significant money headed in this direction. But we did want to draw your attention to the benefits, which is on the slide with the boxes, as it were, where if I start with the left-hand box, that through the savings that have been made in bed reductions, £435,000 worth of investment has now been made into community forensic services. So that's providing the specialist support in people's communities post-discharge. And having started life as a social worker who was working in inpatient units in secure settings, it was one of the hardest things to do, was actually to secure a discharge package in the community, and to work with local authorities, and in those days, shows my age now, it was primary care groups in terms of how do you get that safe wraparound support and crisis planning for an individual back in their home area. And so that's a significant sum of money that's being invested now in community services that has brought additional funds into our services. There's also funding across Devon and Cornwall for additional specialist support in the community for people who have complex emotional needs, also previously known as personality disorders, and also considerable investment in intellectual and neurodevelopmental disorder. Because if you think it's hard to secure safe community packages for people who have been in secure care if you have a mental illness, just imagine the additional challenges when a resident has a learning disability and or autism. So this is highly specialist and complex work and requires lots of liaison and interface across health services. And then there are non-recurrent investments that have been made available to support with training. And I know we said we didn't have any pilots, Kate, but on occasions we've been piloting new concepts or new services to prove concept. So as you can see, there's a little bit of investment there. Now, we are rightly proud in Cornwall of our inpatient unit for child and adolescent mental health. Sowena is actually a national flagship in terms of the quality of care that it provides, but also the whole system will be forever grateful for the capital that was made available to us. And at the time, and this long predates me, it was seen as a once in a generation opportunity, and I would say it still is once in a generation opportunity. It's a fantastic service. But our aim actually is to keep children out of hospital. We all recognise that actually hospital is absolutely the last resort. And we have been able to use some of the investment from the provider collaborative to really invest in some of those specialised services in the community to either keep children and young people out of hospital or to keep them in hospital for the minimum amount of time and to then bridge that back into their homes or place of residence, because some of these children are looked after children and in specialist placements. I'm not going to go through the whole detail, but I did want to bring some colour to those slides, Chair. Mel.
Thank you. So what Debbie's been very modest about is that since her arrival, which I'm sure you're all very clear about the benefit of, we have certainly noticed the benefit within the provider collaborative, and Debbie's taken a leadership role on learning disability and autism, which has been really, really positive and helpful and been instrumental in us securing the capital for the learning disability and neurodiversity unit, which will bring more people closer to home. So I wanted to note that, and also the engagement of Cornwall Partnership Trust has always been one of the more engaged partners in the collaborative too. So I wanted to recognise that. So with Debbie's leadership and experience and the opportunities that she's described, we've been talking between us on what other opportunities are there, and some of those are set out here. So joint working, as Debbie said earlier, is something we do anyway, but moving into these much more formal arrangements and using them to give a power boost, if you like, to that joint working has been particularly useful. So some of the other things we are looking at is the right care, right person work, which is, I'm sure some of you will know, but that's the work being led by the police, for all police forces, not just Devon and Cornwall, about making sure that people who have mental health problems and presentations are cared for in the right way at the right time, and that the resources that the police use are also used in the right way at the right time. And there's some really good joint working going on about that, and very positive discussions, and Cornwall actually has a lot to offer into that partnership about strong relationships already. You'll have seen some of the terrible stories nationally about the quality of inpatient care for people with mental health problems or learning disabilities in a number of places, including the inquiry into the services in Essex and the review of services at Edensfield in Manchester. And because of that, there's the National Transformation Programme for Inpatient Care. We've had a discussion about how we might look at that within the regional provider collaborative, but particularly Devon and Cornwall are having a conversation about how can we look at that together to ensure that we are really clear jointly that we have good care and we're providing it or commissioning it in the right way, but also by being bigger than just our own organisations, we share and learn and have an external critique in the very positive sense of that. We want to look together at our response to, I think you use a different title in Cornwall, my apologies, so we call it first response, but our emergency response or urgent response, how that ties with the 111 button 2 work. And then I've talked about already the development of the learning disability and autism service for the service for mental health service for people with learning disability and autism. So we have huge opportunities in there and we're beginning to build that work together. So we've recognised we have common issues. We've committed jointly to doing that work, and our Senate has, as I've said, people with lived experience and experts by training as well. We work with Live Well, who are the CIC, who provide services in Plymouth, but they are commissioned by Derek, by UHP, so that commissioning arrangement is slightly different, although we're in conversation about that. Between us, another form of collaboration, my chair, Andy Willis, and Margaret and Debbie and I have done some work together on how our organisations work together, and I'm sure you're aware we've appointed joint non-executive director. So there's plenty of opportunity, and in fact I think that I would say the more we talk about it, the more opportunity we discover. For example, we had a brief conversation earlier this week about our CIO discussions that are going on and digital work. So there's plenty to do and look at together. And I suppose just in summary, I know you're keen to get on to questions, we're very clear we share common issues of demography and geography, albeit that there are differences too. We have massive challenges around workforce. I think we could absolutely make Cornwall, Isles of Scilly and Devon the place to come and work and enjoy work in the mental health and learning disability services. There is huge potential to look at the rurality as something that gives us an advantage if we work through that. But also making sure that the people who need the services we provide get the very best deal out of us and are part of designing them for the future. So thank you, Chair.
Thank you.
Well, thank you to all of you. Thank you for bringing alive the slides. Crikey, there's a lot there. Colleagues, over to you from that rich presentation. So, Andy.
Hi Mel, Andy Sant, different lifetime. Yeah, I'm Prime Care Partner member. So fabulous. Thank you very much indeed. As John said, that really brought it alive. And if I think back to my days as a provider executive in the mental health space, the thing that kept me awake most was the people under our care doing harm to themselves and doing harm to others. So you've put a narrative here around some positive outcome benefits for patients with reduced length of stay closer to home. I'd almost be keen to hear more. What other benefits have you seen? Have we seen a reduction in suicidality? And looking to the public health suicide strategy, have we seen a reduction in harmful outcomes, and really a richness there? So I'd almost want to hear more in the future. So John, if we could
if you can answer those, fantastic.
I can answer some of that. So the suicidality for people who are inpatient care is already quite low in Devon and Cornwall and in the services that we commission, and that's been because of a commitment from both Cornwall and Devon to really focus on those areas over many years before the provider collaborative. So the harm of suicide for those who are in our services actually is lower. The issue is the harm from suicide for the general population, which, as I'm sure you know, and I think it's what you're referring to, both, the whole region is a much higher, has higher than national rate. So I think the focus on that is a really important piece of work for both Devon and Cornwall ICB and ICS partners to work on. the issue about harm other than suicide to self is an area that I'm not as conversant in the detail of Cornwall, but in both areas, as I understand it, it remains high, but has significantly reduced. And that has been around the work that Debbie touched on around looking at trauma and the impact of trauma. But again, it's a discussion that is part of the work of the Senate to see what else can we do and how can we pick that up. And then the harm to others, in the services we commission through the regional provider collaborative, you will understand that often, although not always, that harm has already happened, which is why, or has a very high risk of being a near miss, if you like, has come, why people have come into our services. So the outcomes for both sets of our services and the wider region in the main are pretty good for that, but they're very small numbers, and I wouldn't want to in any way underestimate that or underestimate the risk and the keeping you awake at night thing that you talk about. But again, the focus in both collaboratives and I know in both trusts and in Live Well, to be fair, is about reducing harm and risk of harm to self or others. So that's that work around QI, risk reduction, etc. is sexual safety as well, is our ongoing work streams, which will be which we collaborate on anyway.
Very good, thank you. Rachel.
Actually, it's really good to hear the presentation and hear it brought to life as well. And we're obviously in the process of reviewing with a view to extending it, and I'm really positive about that. I think there's an opportunity. We've talked about this, and you touch a bit on it on that slide, thinking about more strategically about the workforce, because one of the rate limiting issues around the ambition is the workforce in mental health, but it's also getting a particular type of workforce around in the community and in some of the areas you say that are really hard to work in. And I know that there's a conversation due, isn't there, about actually through provider collaboration and the collaborative, whether we can think more strategically about what the workforce looks like in mental health of the future, and link back to the fact that we've got HE coming into NHSE, so we've got a whole kind of different way of working around workforce training and development. So there's a good opportunity there, I think.
If you'll forgive me, I'd like to sort of ask a question that's related to lessons we can learn as an integrated system from this provider collaborative approach. I was absolutely fascinated by the Senate concept. It's hard when you look at the satellites around it to pick out any that's more important than another. But there are two that particularly interest me in terms of how we develop collaborative ways of working within, say, an integrated care system in Cornwall. And one of those is giving each partner and locality a clear and equal voice. And the other is new ideas, approaches and solutions using spectrum system voices. We often hear about pilots being landed, but if you're working in a collaborative delivery model, I'm assuming what you mean by that is that anything new is shared and discussed around the collaborative and evidenced for its possible impact, rather than being something somebody wanted to do and got on with. But I just think that maybe we need to have a think about this particular approach too. And my question really is, you say it helps, it's the heartbeat that drives delivery. Is that because partners signed up to it, feel assured, and maybe there's something around risk as well in this, that this is the right way to work together?
Yeah. If I go to your bit, the first bit about the localities and connections, so in the regional provider collaborative, what's been really, really important is, although DPT is the lead provider, we have a governance framework that's a risk and gain share, and that's proportionate to population. So in effect, you get that amount of weighting weighted by your mental health population, but with a commitment to try and resolve equitably, and touch wood and famous last word, we haven't had to take anything further than some challenging discussions, and they have been quite challenging, but have done OD work with the executive group where the work comes up through to the Senate to say, this is difficult, but let's let's hold to our principles. I'm not saying we won't get to a point where it has to, in the end, come to my board. Regions sit on the executive committee as well, just to keep that oversight. So that works well, but I'm under no illusion that that's because so far, as you'll have seen, everybody's had a benefit. We will get to a point where somebody's going to end up with a disbenefit, and that will be more challenging. That's why we're trying really hard to do the OD work. And then the bit about the Senate, sorry, John, did you?
No, I've got 4 questions that want to be answered.
And the bit about the, your point about the, does everybody bring, so they have a set of principles, and I can't remember them all, but basically, so I'm oversimplifying, no idea is a stupid idea. If you've tried it already and it didn't work, don't just start from that point. Add in why it didn't work, and then take it away. We work together, and that failure is okay as long as it's if a planned failure, but you know what I mean. It's not random failure. It's that actually we tried, and they're very clear about that. And at the moment, they're working through developing even more the QI sort of framework within which to work. I mean, it's work in progress, but it's absolutely not a mental health and learning disability specific thing. It can apply.
Okay, thank you. So we've got 4 people who want to ask. We've got Kate, Patrick, Carolyn, and then Rachel. So Kate.
So one of the features of things that are working really well is that everybody thinks it's easy to get into this space. So I don't know how many years ago I was the National Director of Forensic Modernisation, which is where some of the things we learned around how you aggregated a pathway of care, particularly for forensics, would make a difference. I was the Regional Director of Specialised Commissioning when these were kicked off. And so we sort of knew, didn't we? If you had A, B and C service, then you'd have D, E and F utilisation. So there's loads of work behind this that has then been brought to life by great partnership working, difficult conversations around how money will flow and from different places, and investment in locality services. And that's for all of the specialised services that have come through here. So parts of reflection that when we're talking about acute collaborative, it's not that easy. It doesn't just happen because you decide to do it. There's all the stuff that's behind it that sets you for success. And I don't think we should miss that in here. So, the numbers of years of slow burn to get to the point where it could be delivered. The leadership around making it happen, and some of that, it wasn't easy. I mean, it might be great now, but at the start it wasn't.
We had our moments, Kate.
We did have our moments, and also I had moments with Stuart Bell in Oxfordshire. I had more than one collaborative developing at the time. There is just something about the being real about how it comes together. And then if we applied it to acute adult mental health services, it may not feel quite so beneficial because there isn't the same fat in the system to take out for reinvestment as there was in forensics and perinatal. I imagine perinatal was investment. So then I just want to say Joe McAvoy is the reason we've got a Tier 4 CAMS unit in the Southwest, which people might not like, but it's true. He's the chair of our VSC, but he lobbied very hard for CAMS services in Cornwall. So I just would quite like to say that because he's part of our board by extension. And then my last is a challenge really, because Kate Kinnally and I had a conversation around dual diagnosis, complex needs, and how people who don't fit into boxes can be served by our services. And that sort of feels like our next step of how we pull together social care, third sector, statutory delivery for some of our riskiest people, both to themselves and to others. And it would be great if we could see some sort of new collaborative growing in that space.
Okay, cool. So what I'm going to do is I'm going to ask for Patrick, Carolyn and Rachel to ask your questions, and then if you can capture them, 3 questions, and then respond to all of them in one go. So we're just running out of time. So Patrick.
So I'm Patrick, Director of Workforce and OD for the ICB. Nice to meet you, Mel. I wanted to pick up that theme about workforce, famously challenged mental health workforce, and I wondered what the leverage there could be of the collaborative for that. Thanks.
Carolyn?
Mine's not actually a question, mine's an ask, please. So there's a paper coming in this board about research and innovation strategy later. And one of the priorities in there is about promoting and enabling mental health and preventing illness around neurodiversity. So I would really welcome the opportunity to talk to you further outside of here, because one of your opportunities that you've identified is about bringing expertise and innovation together to deliver effective change. So can we link the two things in? Thank you.
Sure, I'd be delighted to answer that one. And Rachel, your question or observation?
Yeah,
please.
quick comment. Dual diagnosis, absolutely. I think I've been CR We're With You provider this week, and you know they still know that this is a real challenge, and I'm sure that's the same for colleagues across the area. So I would support Kate's comment. And then secondly, your examples around how you've released some funding in the system and then reinvested it, and they are provider funds. But I was wondering, in that sort of what we call channel shift, or financial channel shift and release, is there an opportunity to reinvest in preventative approaches that then would reduce your demand? So I think it was a question, is that in your heads as a sort of development approach,
Okay.
or are you still thinking about treatment services and specialist treatment services?
Yeah.
Well, maybe I'll pick up the money bit, and then you could. So I think there's a couple of bits there. So first of all, I'm going to gently challenge Kate when she says there's less fat in acute mental health resources than there was in forensics. So I'm not challenging that statement. But what I'd like to add to that is, nevertheless, there is an opportunity to take the principles of provider collaborative working to actually work on an open book basis to say, this is the quantum of expenditure across health and care in Cornwall and the Isles Scilly that we spend on mental health, learning disabilities and autism, so that we have that quantum, and then we say, we recognise these are our challenges, and we get into a value conversation about, are we targeting that money currently in those areas of the greatest need? And then that's what will help us, I think, Rachel, more around the prevention space. Because certainly if you look at some of the recent cases that have come across the coroner recently, addiction is one of the significant drivers of or contributing factors of some of the deaths that have been happening. So I think there is an opportunity for us to really look in that space. I think the second thing is that the provider collaboratives have absolutely shown that this isn't just an NHS hierarchy, that this is actually the NHS proudly sharing the space and using the power of convening to bring VCSE, independent sector, community interest companies and service users and carers into a space to collaborate. And I think through that we could still get some greater value, and we may agree some channel shift between us over time.
Well.
Yep. So to absolutely endorse what Debbie said. So I think to Kate's point about acute general work, no, it's not that simple. And I can possibly comment about acute colleagues, but having been an acute chief exec, I know which job I think is easier. So I'll just leave it like that. But but I think seriously to the point, I think, is it Nigel, sorry, made Neil, I can't read from here, sorry, made earlier about, is this replicable? It's absolutely replicable. And I think that's something that the acute provider collaborative needs to perhaps think a little bit more about, which I've made the point in Devon.
And going back a bit, so because you can't start from this point, you have to do the work that you did to get to this point.
And it's a lot of work. Yes, I agree. I'm happy to have a conversation about that outside. In terms of the points about the moving the money around in the acute mental health, in local services, I might describe it rather than just that you're right, there isn't as much fat, but if you look at Devon's spend on mental health and learning disability, so I will always argue it's nowhere near enough, and Bill Shields, the CFO for the ICB, will have a different view, but there you go, he's wrong and I'm right. But however you argue that, the proportion of the spend is, and this is Devon, in Devon, the ICB spend, and it's only the ICB spend, only 51% of it is spent with the mental health NHS providers, so us and Live Well. The rest, the bulk of the rest, is spent either on prescribing. I have a view about whether that should go in that pot anyway, but it does for now, and we'll argue that. But actually, 30 odd % is spent on placements, and that's the complex care. And we have in DPT, and we're sharing, and we are taking this in to the local provider collaborative, and we've had early doors discussion. I'm doing exactly what you were asking, Rachel. So we've looked at those complex care packages, and over the not all of them, there's loads of, but over the last 4 years, we've taken out 16 million pounds and invested those in a range of things, and there's plenty more to go at. So that 30%, just to give you, is about 80 million pounds. So it's not, but there's still a way to go to get a better service. And then to your point about there were some treatment gaps that we needed to fill, but actually what we're trying to work out now is can we get even further upstream. I think the other bit, though, I would want us to always hold in mind is people with serious mental illness or with complex needs around a learning disability or neurodiversity. That's a different thing. I'm not suggesting you're saying this, Rachel, than wellbeing services or mild to moderate depressions and anxieties, which are really important. But there is also something about, are we making sure that the people with the highest level of need, the greatest disadvantage, are getting the best service at whatever level they need it? And we prevent what we can, absolutely. But when people are that unwell or need that, have that level of need, that they're getting the support they need.
Pick up on Patrick's and Carolyn's points before we finish.
Sorry, and then, yes, very happy to have a discussion about R&D. That has been part of our discussion. I think it would be helpful to really focus on that in both the regional and the local work. And to your point about workforce, there is already work ongoing about workforce. And one of the pieces that's happened between Devon and Cornwall already is a bit of show and tell. So we know, for example, I know there are others, but I can remember the acronym is the CAPS. Sorry, yeah. The CAPS workers is something Cornwall's led with. We've done some leading work on some of our apprentices. If you look at what we have between us and non-medical RCs, etc., so when we're short of consultants, there's a lot in there that just by working together we could, even if we all did what each other was doing, we'd get benefit. But the overarching benefit, I think, of working together is making this a great place to come and train and stay or come to as a mental health or learning disability professional of whatever type, because between us we could offer the whole range pretty much, and some really exciting and innovative services, and you get to live in a great part of the world.
I could just ask a few questions myself, if I may. Debbie will have seen this because you had the full papers and the discussion. Unfortunately, Mel, you won't have seen this, but this morning we went through some of the video vignettes that we've got in terms of feedback from individuals, and I was particularly taken by the music therapy and the Argyle types of things. And then we had a presentation from our West ICA where they were talking about some of the work they were doing, and also about social prescribing that we talked about as well. So I guess I'm not being a clinician, I'm just trying to get my mind around I think it was Rachel's observation about there are certain things that we should be doing before they become clinical as such, or kind of thing, about doing things locally. Would I assume that the Argyle work, I'll look to Debbie for a moment, you know what I'm talking about, the Argyle work and the music therapy, is that treated as prevention in your world?
It's hard to classify it, John, really. I mean, some of it could be prevention, some of it's early intervention.
What I'm trying to understand is we're often separated by a common language, right, on a variety of things. But when we talked earlier on about £12 million as an ambition out of our 1% for total being in prevention, I'm trying to understand whether there are certain things that we're doing, well, that actually is prevention, or whether in fact that's not. So not for today, but I think trying to understand what we genuinely understand, because it would mean quite something different, Neil, to the local colleagues if they said, hang on, we're doing music therapy. And because part of the challenge to the workforce one might be, we might have people who are third sector, if Emma was here, doing things locally at place level, getting in early and doing stuff.
And isn't, John, just preventing a condition emerging in the first place? That some of our prevention work is, you know, if you think back to the Mental Health Act, the spend that commissioners, there's a joint duty between the local authority and health, that is to prevent a readmission to hospital. So you commission aftercare packages, and Kate's mentioned personal health budgets earlier. So prevention isn't just about preventing an initial onset. Prevention is much wider than that.
Yeah, no,
I'm being obtuse.
No,
and
no,
not
I'm trying to
giving you
understand
a
for our
black
future.
and white answer.
I think we possibly understand a bit more what prevention might mean in other areas. It's just our first sort of deep dive into mental health, trying to understand, for someone like me, what that might mean would be helpful.
So I think secondary prevention is the avoidance of a readmission. Primary prevention, if we want to be really ambitious, could be good self-esteem and decision making that young people form through their
Parent
adolescence
education.
that allows them to make decisions for themselves as time goes on. So I think the comment Rachel made months ago around us working out what prevention is, and then we can say what our benchmark is. And then, Neil, I don't know whether 12 million over 5 years is ambitious or not. So we just need to, as part of our financial strategy, I think we need to be clear on a year by year what we are going to move into prevention and then track to see whether it's working or not.
So, Margaret, as we're drawing towards the end of this, is there anything that you would like to add?
No, I think
You're very happy with the way it's going on there? Okay, I'm just looking at other colleagues' types of questions or not. So, last couple of minutes, what would you like to add after the debate? What happens next? Because I'm looking towards the recommendations, and I'm not 100% sure what you're wanting the recommendations. But if we park those for one moment, what would you like to see come out of this?
So 1, demystify provider collaboratives.
Very helpful.
2, acknowledge the benefits that have already been brought to this system, which I hope we have been able to achieve today. 3, note and work on what can we learn from this and spread into other ways of working. So I think Neil very helpfully has drawn those links. Kate has very helpfully drawn the links into the acute provider collaborative. And I think 4, really just Mel and I are proud to be here today as 2 mental health chief executives. Because we hear a lot about urgent and emergency care, and we hear a lot about our work, rightly so, in the acute sector, but working together and collaborating in this space of mental health learning disability across all ages is also a really, really key, important part of working in a system.
So can I suggest that we endorse the work and that we acknowledge how hard it is to make something feel as simple as you two are making it feel, and that doesn't come without an awful lot of executive and board support for working in this way. I think we should formally endorse it.
I agree. Can I just look to everyone to say we formally endorse this as? Yeah, thank you. I think we should also take Debbie's point there about demystifying provider collaboratives. I've learnt a huge amount generally, but having read the paper and having heard you articulate it, I'm not going to say I get it yet, but I'm getting it a bit more. So huge thanks to that on that. Learnings, definitely. And the reason why I was saying the recommendations, what next, is I saw, I think, somewhere in the paper about coming back maybe every 6 months with us. We could invite you back maybe in 6 months' time to say, have we learned? Have we done much about that? Is there anything you want from us? Have we finally caught up? And would that be an idea? Would you be happy to do that? Yeah, so let's do that in the new year. Happy to finish there, everyone, on that and say thank you. So I'm going to say thank you very much indeed. Thank you very much. Excellent. Great presentation. Thank you. Right, colleagues. So where are we? So, unlike me, I'm 60 seconds late. So we're going to break now for lunch. And can I make a suggestion? Because there's some large items after lunch. Can I suggest we're back at 2 o'clock, please? And then we'll pick up straight away with Nick's presentation. Okay, see you at 2 o'clock around. Thank you ever so much.
Thank you.
Everyone. So, good to go? We're in good. Thank you very much. We're now live, everyone. So we're continuing on with our meeting. Now, John, welcome, John, from the Academic Health Science Network. You're going to be with us for an item later on. Just so you know, we had a slight move around of the agenda. So actually what we're going to do is we're going to go straight to Nick, because he's going to present the Health Watch annual report, and then we will do yours, if that's all right. Is that okay with you? So Nick, from your perspective, please, Health Watch annual report.
me ask you to talk into the microphone.
Yeah.
Right, Nick Bailey, CEO of Healthwatch Cornwall. This is my first annual report. It was for the year that I wasn't there. I started in May. In fact, I came to my first ICB meeting in May, less than a week after after the final interview. So I'm still relatively new at this.
Very efficient.
So we've had a very successful year. We've engaged almost 1,000 individuals and collected their stories. We've signposted almost over 350 people, and we published 3 major reports which have been acted upon. And one of the things people don't always realise about Healthwatch is that we have a statutory duty to collect public voice and present it to the NHS system. We also have a statutory power that when we make recommendations, there's a requirement on the service those are made to respond within 30 days, or it can be escalated to Healthwatch England and the Department of Health and Social Care. So we do have some power to our arm as well, and the associated responsibility that goes with that. So our reports, Cornish Communities in Mind about mental health and suicide prevention, those recommendations are still being worked on and acted upon. 15 Steps for Maternity, part of the coming out of the Kerno Maternity Voices project. And Hear Our Voice, our most recent report, Improving Dementia Care and Memory Loss Services, where we had a very successful conference in May regarding that, and there was a very long list, 40 recommendations, which are being picked up and followed through. So that's the description of our sort of influence. The sorts of differences we've made, listening to unpaid carers, talking to people from different communities about mental health and suicide prevention. Oh, sorry, John, can we move on, please? Thank you. And once more, and again. Responding to parental concerns, children with autism, and made differences on how the Royal Cornwall Show was organised. And the feedback about dental access contributed to the extra 1,000 appointments for emergency NHS treatment. Next slide, please. As well as the Kerno Maternity Voices Partnership, that's contributed to services in Cornwall being ranked as some of the best in the country. We helped 551 students, or spoke to 551 students, a third of whom didn't even know that 111 existed. So that was powerful. We've worked with Team GP to make people aware of the range of services now available at GP surgeries, and that's been an interesting piece of work. And worked with health and social care providers about poor end of life care during winter pressures, and also more widely. And as a result of that, the Palliative and End of Life Care Alliance, that used to be an advisory group, is now being reinstated and is now working again, and we're very much part of that. I might be chairing it, I'm not sure. Next slide, please. In terms of how we made a difference for the community, it's about signposting. We give an awful lot of advice to people who just don't know where to turn for help, or where the help might be, or even if it's available. We get services to involve public, so we're very much part of that co-design and listening and co-location approaches. And improving care over time, because we work behind the scenes, hence the seat at this board, at these tables, and many others. We're in a position to raise issues and help bring about change by making people aware of what the public's concerns are and examples of practice and where things haven't worked, and also complementary where they do work. Next slide, please. Honestly, I'm not a government spokesman. Hearing from communities, we are focusing on trying to do more outreach and trying to reach those people who are less traditionally engaged or more difficult to engage. We've worked with the deaf community, we've worked with organisations combating gambling harm, and a number of community groups listed there. I don't know who those are, although I do. Memory Cafe Network we've done a lot of work with, and that was very much part of the dementia research element for those reports. Warm Hubs you're familiar with, Apologies, I haven't come across rice and peas and chronic sisters yet. Next slide, please. Partnership boards, something you may not be aware of. We run the 4 partnership boards, which are currently operating in Cornwall, commissioned through Cornwall Council, where we bring together the service professionals, people who commission and direct those services, together with users, so experts by experience. And those boards that are currently running are for carers, learning disability, autism, and older persons. And we're in a recontracting or contracting situation at the moment, and mooted is partnership boards for mental health and for dementia. And we've been keen to emphasize that dementia and older persons are 2 very, very different areas, and there have been suggestions that they could be conflated, and we definitely do not want that. 2 very different sets of expectations and needs and responses for those groups. Next slide, please. The Kernow Maternity Voices project has been very successful, and has reached an awful lot of people and contributed to a great deal. It's part of a statutory or a commissioned move that is national across the NHS system in England. Ours has been running for quite a while, and the lead person for that is hosted within Health Watch Cornwall. There's also a partner project to that, which is Kernow Parents' Journey. So, and something like 1,200 service users have been reached through various media and exhibitions, etc. And we've also worked for that project directly with the Isles of Scilly. On the Isles of Scilly, where Health Watch Cornwall isn't representative, there is a Health Watch Isles of Scilly, who's obviously a much smaller organisation, and we have links with them. We also celebrated 15 superstars across the professions in perinatal, amongst professionals and support staff. Next slide, please. We rely greatly on volunteers, and then we have a lot of volunteers, some of whom appear in other places, such as patient participation groups, and some who are just keen to help health and are interested in speaking to people. We do a variety of drop-ins at various facilities and institutions, emergency departments recently, and minor injuries units, doctors' surgeries, but also more widely at various support groups we will attend, and also in public spaces, libraries, supermarkets, community spaces, etc., to help collect people's stories. We even got some stories from the Royal Cornwall Show, where people welcomed the opportunity to talk to us and explain some of their difficulties and frustrations with the health system, and now they will go into our thematic analysis. Next slide, please. Looking forward to the coming year, our top 3 priorities are going to be increasing understanding and amplifying the views of those who are not heard, who maybe experience health inequality, and also for children and young people who are less represented. We're conscious of that, so that will be a target area. Working with the integrated care system to better understand the challenges faced, and we're obviously aware of that with primary care services and dentistry, and we get a lot of traffic about that. And continue to monitor the implementation of our recommendations from published reports, and that current work is around dementia, mental health and suicide prevention, and end-of-life care. And I'd like to finish on a note, so next slide, please. This was a comment we received this week, which during a management meeting, which was very fortuitous for us. So very, very grateful to Zoe Locke at CFT for that, and thank you very much, everyone. Any questions?
To you. Any thoughts, Debbie?
First of all, thank you very much for the shout out for Zoe Locke. And she's a relatively new in her current role within CFT, but she's already made great strides in terms of patient and carer engagement in our organisation. So it's really good to hear, independently of the trust, that she's having an impact on partnership working. And I think she's absolutely right. Our organisation does applaud the work of Health Watch and benefits greatly from the joint work, but also the independence and the scrutiny that you bring, because it's not easy, is it, Nick, for you and your team to be in that interface. I was also pleased that you name checked the Isles of Scilly, and certainly whenever I go to the Isles, I always pop into the Health Watch office because they will tell me what is on local people's minds at the time. And I wondered whether there was an opportunity either through you or through a different slot for us to receive the annual report of Health Watch Isles of Scilly at this meeting as well.
Due to meet with them at some point soon, I can ask that question because they are also part of the ICB and the ICS, and their voice, and also the unique circumstances and frustrations and barriers that they face to healthcare. I know that we're aware of them, but they do need to be voiced.
Well, and Kate to be fair, does a very good job at ensuring that, and I don't think a meeting goes past without some recognition and nod to, and this is how we might apply that, or this is something that could be innovative for the Isles of Scilly. But I think in the Health Watch space, given that they do collate surveys and an annual report as well, I think it's...
I take it they have their own annual report?
I don't know, I can find out.
Because I think if they do, we ought to receive it.
I agree.
Yes.
So could we just make that as an action point, please, to follow up on that? Any other questions? Yeah.
Rest I don't need to. So the report, the annual report obviously shows the breadth and the depth of the work that Health Watch is doing across Cornwall and the Isles of Scilly. In terms of our setup, the provocation around are we going to really co-produce and involve people was there right from the start, and we've probably not been as great as we can be in our first year, but we're learning to be more in that space. Just wondering, with the reports that have been produced around dementia, mental health and suicide prevention and end-of-life care, how we track whether we are moving sufficiently quickly with the things that we know we need to do based on the feedback of people who use those services?
That's something that we're looking to work on, and we're developing a model for determining impact, because we understand we're very good at collecting information and being able to present it and say, this is what we found. It's taking that forward and saying, what has been the effect of those outputs? How have they been received? What action has been taken? What conversations or developments have taken place as a result? And that's something we're not so good at the moment, but we're developing a methodology so we can present that, and that will complement the work we want to do with Lucy as well.
Just wonder, in our new operating model, the chief nurse would also be responsible for evaluating the outcomes of the services that we plan for our population. So I just wonder, Susan, whether we could do a piece of work towards the back end of this year, because both dementia and end of life, we're fairly clear that we're letting people down. So what we're doing in terms of our service planning that improves that, so that we are being able to respond both to your provocation, but also what people have taken the time to say about their care and that of their families.
Okay.
Any other questions? Rachel?
Really, thank you for the report. And I was talking in the break about the core contract work that Health Watch has done as a statutory function, and then the project work done. And we have been involved in commissioning some work, which was a competitive tender, and which Health Watch won and delivered that as a really good quality piece of work. So I guess there's a sort of recognition that you do your core work, but you also have the option and where you have the funding to do bespoke insight work, which is much more detailed, and if it's resourced appropriately. So just thank you for that work.
Yes, no, we have developed a research function, and we've developed the expertise and methodologies that we can produce meaningful understanding from what is very subjective information coming in a variety of forms, and make sense of that, and then identify where things may be idiosyncratic, referring to one episode or intervention or event, and others where it's popping up in different places. So there's clearly some sort of systematic driver that's indicating, and that's what we found. And in those reports, that was really focused down onto to understand it for those particular areas, mental health, suicide, end of life and dementia. and we got a huge amount of information. But as a result of that, we could produce a very useful and meaningful report.
I'm just wondering how that aligns with our engagement strategy, because there's a whole host of work that's through the Healthwatch core contract, but also could be augmented by specific inquiries we might have with more of our underrepresented communities. So I just wonder whether we could pick that up offline, so that with our whole board's working together rather than us doing isolated pieces of work.
So lots of nodding going on there, for sure. Okay.
I think we're happy to do that.
I've actually been going to be taking part in a NHS England project, which brings and supports Healthwatch and ICSs to work together on discrete areas of work. So we'll be bringing that back to board to update them on.
Great.
Thank you.
Thank you very much. So the recommendation we have, colleagues, is the ICB board members are asked to receive the annual report from Healthwatch Cornwall 22-23. I take it you're happy to do that? Yeah, thank you. And we've made the note that we need to invite the Isles of Scilly Healthwatch to get some feedback on those as well. Okay, lovely. Thank you very much, Nick. So we now move, we can have lunch again if you like, or we can move on to the next item.
There's not much left.
That's right. No, all right, let's move on then. So welcome to John, but Carolyn, you're going to introduce this particular section and then hand over to John on research and innovation strategy.
So, thank you very much. So, I'm going to take the paper as read, and there are two embedded documents in this paper which had a lot of information attached to them. But I just want to kind of draw the board's attention to the fact that this is a follow-on from a piece of work that we introduced in May at the board. At that point, we brought a paper with an overarching view of what was happening, and this paper really is kind of giving further detail, and also to kind of just go through the 5 missions very briefly, but to pull out the fact that actually this paper now, having been through the board this morning, actually complements a couple of the earlier conversations. So one around the civic universities and the enabler that the universities can have, because they are a big partner in this piece of work. And then the other one is obviously about the mental health deep dive that we had, and my ask of the collaborative to be able to kind of work with them around research and innovation. But effectively the partnership is Devon ICB, ourselves, Somerset, University of Exeter and Plymouth, and the National Institute of Health and Care Research, Clinical Research Network, and the Applied Research Network. And for the purposes of this strategy, it sounds very odd, but this is being called the Peninsula Strategy. And I know it's not quite the definition of the peninsula as we would know it, but this is kind of how we're working at the moment. So the paper outlines the fact that we've identified 5 key priorities. And you will see from the paper that they actually really align well with our own 5 clinical priorities here in Cornwall and the Isles of Scilly. So if we look at the long-term conditions and multiple and frailty, it sits with our clinical priority of intermediate care. Mental health around neurodiversity, children and young, anxiety, learning disabilities, sits with our clinical priority of MHLDA. Mission 3, which is the immediate, compassionate and cost-effective urgent care, sits with our urgent and emergency care. Cancer, obviously sitting within our planned care, and maternity and neonatal, sitting with our priority of children and young people. The thing I'd like to say about these is that Kate and I have been involved in this probably since December. I sit on the working group and Kate on the oversight group. And from December, I have been meeting with Alistair, Adrian, Fraser and Richard Lawn. I hope that's how you say his surname. Lawn. Apologies. And I've shared the papers with them and had conversations with them. But one of the things we probably do need to do from this is have a wider shared engagement with our clinical teams. And I think that is recognised. However, the AHSN, for their part in this, they have taken the role of facilitator, And I have to say they've done an excellent job around it, but they're also facilitating some of our meetings. So they met recently with RCHT and CFT, particularly with Aidan and Alistair. And one of the things that we're kind of garnering from all of these meetings and this work is that we do need to align our research and innovation leads and champions and the pieces of work that we're all undertaking, because I think some of them sit nicely within the strategy. So I think the paper is self-explanatory. I'd like to think it's self-explanatory, but I would stress it had to be read with the other embedded documents. But I think there's an absolute need for us to do this. We do have a duty to promote research and innovation as part of being the ICB, but also as part of the integrated care system. We recognise that obviously the more we research, the more we innovate. A lot of the innovation hopefully will have a positive benefit of many of the things that we're trying to tackle at the moment, things like our recovery programmes, our financial programmes. So it is really important that we move forward with this. We have a very willing and keen cohort of people who are looking to promote all of this, which is why it's really important that we try and bring it all together under this kind of research and innovation strategy. I think I'd like to leave it there, if that's okay.
So if we hand over to John, of course, John is the chief executive of the Academic Health Science Network for this area. So I can hand over to John. John, bring your hands.
Thanks, John and Carolyn. So I think I'll just make two brief points, John, before we open to discussion. And the first one is to say that having been involved in helping to develop this over the last 6 to 9 months, I think it represents a really important moment for the population of the peninsula. And the reason I think that is based on my reflections coming back to the peninsula 3 years ago and seeing two things. So firstly, a sense that we have some really significant challenges because of our geography, because of our populations, which are different to other places in the country that I've been fortunate to work in. But then almost set against that, we've got some absolute pockets of excellence, of really great research, really great strengths in different areas, and really great innovation happening. But the big opportunity, I think, is about taking that to a much larger scale. And that's not just about working across the peninsula, but about taking the things that do seem to be working, understand that they work, and then applying them at a much larger scale for the types of issues we all face in Cornwall, but also into Devon and Somerset as well. So that sense of a real challenge that we have, but an opportunity by working together to tackle them, is something that I certainly observed. And for me, this partnership and the strategy that sits underneath it is about tackling exactly those issues. So it's about focusing down on a few issues that really matter. It's about aligning the assets we have around research and innovation more effectively so we get better value from them. And then it's about actively managing a portfolio of work that is driving towards the priorities that you have as a local system for the population that lives here. So I think the opportunity of doing that in a much more coordinated, structured and strategic way is the big thing that we are playing for here. The second thing I wanted to say is there's some great examples of projects in the paper that give you a sense, I hope, of the sorts of things that the partnership as a whole is starting to work on. And some of that is about work that the AHSN will be supporting. Some of it is about work the universities will, individual providers working on, partnerships with university colleagues as well. But there's one example that I draw on is some early discussions we're having about how we could start to take new ideas, new ways of working into work around urgent emergency care. And how we look at getting behind the plans that you have as a system and then bringing the resources and assets we have in research and innovation behind those plans as part of an integrated way of working. So that's working with SWAST, working with providers locally, and working and learning from other places into Devon and to Somerset work as well. And that type of approach around using those assets and resources to take much more data-led approach to the way we design what we're trying to do, how we then embed the right experience around how you understand user journeys and user experience in that sort of work, but then really importantly embedding good evaluation into the way that we test and develop new ways of working, so that as you come out of that test and develop phase, you've got a really clear sense of what works, what hasn't worked, what you want to scale, and most importantly, what might be replicable elsewhere, other parts of the county, potentially out into Somerset and Devon as well. And I hope that reciprocal arrangement of sharing and learning across Devon and Somerset and Cornwall and the Isles of Scilly is at the heart of what we're trying to do as a partnership. So I hope that helps bring it to life a little bit, John. Happy to take any questions on behalf of the partnership because we've been very involved in it, but obviously Carolyn and Kate as well.
Did you want to say?
Yeah, can I just say that this can be quite a difficult space to occupy. So at the start of getting the strategy together, researchers quite like their own research and don't want to share. Universities can be quite prickly about partnership working. And what has happened really beautifully is that people have come together as collaborators, and that's taken some time, but I think we're in a better place for that. Great care has been taken to align the work of this programme with the priorities of the peninsula based on the needs of their people. And I don't think we should lose that in terms of the document that's behind it, but the immense care that's been taken through several workshops with ICBs to talk about how we land this in the requirements for our populations. And it goes back to Elizabeth O'Mahony's point around the Southwest Way, and that we should be working collectively around the things that we do. And then the last bit is around our issues and challenges could be our USPs around test beds and for attracting inward investment in some of the things we need to sort out for our people in the peninsula, and particularly around digitisation and access to different models of care. So I think all of this comes together at a really exciting time for us as an ICB.
Thank you, Martin.
Thanks, John, and thanks for the presentation. Yeah, I think 2 points on the thing and perhaps one question. The 2 points are, like Kate, I really liked the way we were targeting research against our priorities, which I think is ideal, because it targets our resources where we can get the most benefit. I especially like the emphasis on deployment, adoption and spread, because, again, we're probably guilty of finding good things, but then not necessarily adopting them universally or where appropriate. So great on that. My question, and maybe the strategy isn't the place for it, was, is there a place for some sort of objective measure of how well we're doing, whether that's, numbers of new research projects, value of grants, or something that we can sort of say, great, this peninsular collaboration is actually working because we can see growth in XYZ, whatever XYZ is.
It's a great question, and it absolutely is the question that most ICB boards have asked me when I've once talked about it. So how do we know this is any benefit? And by the way, the universities want to know too. So how do we know that this endeavour is worthwhile? And I think the answer is probably on a few different dimensions. So the most important thing that matters, certainly in my view, is that the projects that we take into that deploy end are having a real impact on the stuff that you guys are trying to do as a system in improving health and care services and population health like that. So that's the most important measure I'd start with is, are we really adding to the efforts to trying to support that? So each project that we do at that level of deployment, so at the kind of right-hand end of that innovation process, is about really understanding the outcome benefit, the return on investment you get, and building that into the project level. So that's a project level measures that we can aggregate up as well. But there's some other measures that really matter as well, is about how big and effective is the scale of the pipeline that you're bringing along as well. So we'll be looking at that. For me, this is about good. So my background years ago was working more over in investment and funding world, where this is about building an investment pipeline of what you're backing as a system to say is going to have an impact on not necessarily financial return here, but on delivering a really positive population health benefit in the end outcome of that, and connected to that, delivering that in a way that's aligned to some of the operational challenges as well. So building the pipeline, delivering impact through the individual projects. But then finally, I'd say there's some other good proxy measures we can use to give us a sense of, is our combined efforts here helping? And one example of that is, are we leveraging more investment into the research and innovation pipeline for the researchers and innovators and organisations we're working with, the providers, the companies, the researchers and universities, that is strengthening the pipeline to increase investment. And that's certainly my observation. The origins of this work came from an early piece of work we did on behalf of all 3 ICBs, saying what are the conditions and characteristics of really effective research and innovation systems in other parts of the country and the world. And that's one thing that they create, is this self-perpetuating cycle of a commitment to research and innovation, which then drives inward investment into more of that, which then drives more of that to happen in that self-perpetuating way. So I think those are some examples of some of the measures, but we're working on a clear performance measurement dashboard for the partnership that says this is the stuff that we think will give us the indication of moving towards the overall aims of what the partnership's about.
Rachel?
Well done for agreeing those priorities, because across a number of systems that's quite an achievement, and I guess it's really clear. I guess a bit of a challenge back to you. If you did one thing really well, which is helping translate research knowledge that we already have into practice, that would be a great result. So I guess there's something about a simple, some simple sort of truths about what we need to do. I find that that's frustrating in the system, knowing how much great research there's done and how much money goes into research establishments, and it sits over there. So I've talked to you about this before. And also thank you for coming to talk to the Peninsula Directors of Public Health. We will have research portfolios as well, and are well sort of linked in with the sort of NIHR sort of research networks. One thing that also we do badly in Cornwall is having trials in Cornwall. Okay, Exeter, love it, great, they're falling over each other with trials. We have some good clinical trials, but the wider health trials are not coming to Cornwall, and that's national. And I've seen the register and the recruitment. We're way below all other areas. So again, a metric we could include in that research sort of ambition. Good trials means innovation, means clinical developments, and early adoption of practice. And then my last challenge: where's the capacity to sort of do this, or is it system working that we're looking at, or are we thinking about getting people to do more stuff as well?
You go first, and then I'll go second.
As usual, Rachel, a great set of questions. Thank you. So I maybe just touch briefly on the translation and the clinical trials bit, and then maybe you can talk about how we do it. So on the translation of research, I think one of the things that's most exciting about the first wave of projects that we've started to try and bring into a more active management of a portfolio, which we talked about with the partners last week, is a lot of them is stuff that's been around for a while. And I actually don't see that as a bad thing, because there's some stuff that's been around for a while that we've known has worked in some places, but we haven't systematically evaluated about, if we start to do it at a larger scale, will it achieve benefit? And if it does, then can we do it everywhere? So I think there's that translation of things that we have already done or have been around, and how do we drive them further forward is definitely at the heart of it, not just coming up with lots of new shiny things, because I think it's probably both. We need to do a bit of that as well, but there is a real opportunity around translation of the knowledge that we have. And then probably my mistake at admitting the emphasis on clinical trials, because that is absolutely front and center of this plan. And the reason for that is probably twofold. So at a UK and economic level and NHS level, the effort that's needed to get us to the level of clinical research opportunity that we have is huge. So there's a really big opportunity to go further on increasing participation in clinical research, and the role this partnership could play in really trying to drive that for the trials that will really benefit the sorts of needs we have here. And I guess that's the opportunity of connecting the two together. But that also is a key part of this, because within the ICB's legislative duties is not just about innovation, it is also about research as well, and that is also about research participation. So that is something we definitely need to have in that dashboard of success measures, is are we making material impact on increasing participation in clinical research?
Thank you. So there's a few bits.
So RCHT was one of the top 10 adopters of innovation. I think it was about 3 or 4 years ago, but because the Office of Life Sciences came to see what it was that was in the water in RCHT that meant that people did adopt things. And there is an internal culture around research, and there was a big emphasis on innovation. Now, we will have a Director of Innovation, Improvement and Research, and part of what that post will need to do, linked to the Academic Health Science Network, is generate the interest locally so that we get our innovators. And our research is not all massive scale research, but linking that into inquiry and practice. So I know that Kim O'Keefe is really keen that we generate more and more people taking part in research in the work that they do, both as a way of keeping people fresh on the job and also making sure we're improving our services. And we have agreed that, so I don't know quite how to get into this. From Monday, Chris is setting up a task force. So it'll be news to some of you, that we, between now and October, we have to have a differential offer for winter. And we already know that there are 30% of people who should be going to ED and into an ambulatory pathway. We may not be hitting the 30%. Who's the cohort, and could they go somewhere else? So that's the first question that will be asked of the task force. one of the things we want to build into that is if we make pathway changes, can we use the support of the AHSN to map those changes and the impact of them, but also for individuals being part of that change process? What are the outcomes for business as usual, brackets, because that you never deliver everything all in one go, and what are the outcomes for people using the revised service offer? So we start to grow our evidence for implementation or not as part of the work that we're doing. So we'll trial that with the task force that Chris is setting up, and that will be through the UEC Mission 1. But then if that works, we might want to use that way of working for other things that we do at scale across our system, so that we're building our evaluation into the start of our projects, not retrospectively seeing if it works, then we've got our baselines established. So I think there is real benefit practically on the ground with our people in the places that they work to start pulling all of this together in a meaningful way, so it isn't a strategy on a shelf, it's just the way we do stuff in Cornwall and the Isles of Scilly.
And does that build on John's point about the journey mapping bit?
So that's the point I mean about people who are using a service. We'd have to, at touch points, ask them what they their views of.
So we've got Carolyn, Debbie, and Rachel.
I think I'm going to tie all of those things together, just picking up Martin's point, because that's the reason we'd like to bring back a quarterly report back to the board, is because there is obviously, as John's alluded to, developing the success measures, which are actually about the strategic aims, but then there are also the KPIs against the actual individual programmes, and we're already getting highlight reports from each of those priorities at the moment going to the oversight group. So we are beginning to see where the traction is being gained. So I think when you bring all of those things together, that's one of the recommendations. So we can actually see and monitor that everything is moving forward as we would want it to.
Debbie?
Yeah, thank you. I'd like to congratulate colleagues on this strategy, but also particularly thank John and his team for the proactive way they've actually tried to engage with all going on out there already, and how can we help and how can we pull that together. I think that's been really very supportive, because as you say, Kate, trying to get everyone to share what they're doing. And within our organisation, I was actually quite impressed, having come from Oxford, where I was co-located with a world renowned psychiatry institute department. But actually there's a lot going on in Cornwall, and the thing that's really great in Cornwall is that it isn't just the professors. Now I will give a shout out to one of our professors, because we have a really eminent professor of neuropsychiatry and intellectual disabilities, and he is an absolute force of research production, but also innovation, and he's currently looking at how you can use AI in that space. So if you haven't yet heard of or met Rohit, he is inspirational, but through his inspiration he is now encouraging psychologists, occupational therapists and nurses to get involved. And Margaret and I were really heartened the other week, because one of our nurses wrote to us and said he'd just been part of a paper and it was his first publication, and it was really fantastic. It's about Brain in Hand, a UK digital self-support system for managing anxiety in people with autism. And when you start thinking about how do we make the research agenda real to the public who may be listening, and it isn't just about drugs or really expensive whizzy machines. Some of this is about what things that people can develop that make a difference. I'm thrilled to see the prioritisation of mental health. Delighted to see that Mars is in there, our multi-agency rapid response for children and young people, because that cuts across RCHT, CFT, the council and other services. So that's really good. And also to say that through our partnerships with the University of Exeter, the new Thrive research project that Kate Lation's leading on, which is tackling health inequalities through voluntary effort. And that's public health, it's the ICB, it's folk within our community services as well as the voluntary sector. So
I think we've got some stuff in this space that we should rightly be proud of. And at the end of a long monologue, John, for which I apologise, my question is, do you think that when this comes back to future meetings, we could provide a link to some of our locally generated research papers that have been published, so that we can start to celebrate the contribution of our Cornish people to nationally and internationally published research?
Just before we move on, here, by the way, and Kate, I don't know whether you want to pick this up, or Lucy or someone, but the number of times I go into a sort of a national meeting and I hear someone go, "This is so innovative," I think, aren't we doing that? So if we've got it, shall we just celebrate it ourselves, but maybe just share it a tad more? So I don't know how you want to capture these great moments.
So Rachel and I have spoken about this because I go to lots of regional meetings to hear about the fantastic innovative work of my colleagues, when I know Rachel and her team have been doing it like for years. So we do need to do some sort of log of almost a statement, I think, a quarterly statement of things that we're involved in. Just so, because people are surprised that I'm not more vociferous in our regional meetings, but I don't tend to say much about what we're doing, and I think at times that lets us down. So I think if we could do a quarterly log that we can share amongst us, and then whenever any of us are going to meetings, we can talk about what we're doing. So I think John can help a bit, and Lucy. That's okay.
Volunteers. Thank you. Okay, Rachel.
We just had the same conversation at the region about every document we produce should showcase at least one or two examples of good practice in the region. So there is definitely something about showcasing. My point was about the interconnectedness with strategies. So we've seen a lot of different strategies, and I think we alluded to it today that it's particularly in relation to deployment. We should see mirrored in our other strategies around intermediate care, in terms of organisational development and workforce planning. We should see the notion of taking of research-led practice, spreading good practice, getting people involved and recognising innovation and ambition. I just think it's about embedding the cultural issues rather than just having the strategy. The strategy is great, but you've got to realise it through everything that you do.
Very good. Okay, thank you. So let's try and wrap this up. So a couple of observations, if I may, John. Research and the academic side of it. How much are you planning on working with the team, or vice versa, with you in terms of the replacement to ERDF funding and the UK Share Prosperity Fund, so that we can actually attract funding in here, not just the thinking of it? So a quick answer to that one.
Yes.
Fine, great.
Definitely.
Thank you. And the second one is just building on something that Kate said, that you mentioned that Kim from the shared provider CNO talked about in terms of motivating staff. Let's not forget that research, if we do it well, actually attracts talent. So we should see this for all sorts of really positive reasons. Okay, so we move to the recommendations. Confirm agreement and support the strategy and implementation. We've been able to embed our promoter. Yep, are you happy with that first bullet point? Yep, excellent. And receive quarterly updates, which I think we just talked about. Not just to the strategy implementation, but we're also going to note in the minutes that we're going to be asking John and Lucy to come back with some classic examples as to where we're leading the field. All right. Thank you, John and Carolyn and colleagues, for that. It did run over a bit, but I think everyone's getting very excited about some great stuff, so I thought it was important to deal with that. So thank you very much. Thank you, John. Feel free to stay if you want to, by the way, or if you need to. That's entirely right. Excuse me. Tickly throat today. Okay, so we're now on to Kate Maynard, that is, in terms of integrated performance report.
Thank you. So the report in your pack represents a snapshot of key performance against the system's clinical priorities, against the key NHS constitutional standards, as we usually have, together with our performance against finance and use of resources. I'm going to take it as read. As usual, there's quite a lot of information in there, but we're just going to raise a couple of points. First of all, I just want to flag that for elective, so although the plans to reduce down to 78 weeks for the end of July, that was missed, there are now robust plans to get there by November, which is good. And in terms of the 65 weeks, those plans are being pulled together, and that's been overseen by our elective recovery group and the regional tier 2 oversight framework as well. I'm just going to invite Susan to come in and talk about urgent care, and then Simon to talk about finance and the use of resources. So, Susan.
Thank you. So we've already said it at the beginning of the meeting, we've had some real successes within urgent care, but we've still got an awful long way to go. We've seen improvements in our category mean times for 1 and 2. However, we're still not quite where we need to be. We are seeing some improvements internally. We've had ESIST in, it's been a busy month. We've had ESIST in RCHT at the beginning of July, working with particularly the same day emergency care units. We know that we've got a target of keeping at least 30% of admissions away from our front door, and how we do that and whether or not we can do some direct admissions for our ambulance colleagues into same day emergency care, whether that's medicine or surgery. But ideally what we'd like to do is provide alternatives in other areas than our acute trust. So, for example, we know that we've got our community diagnostic hubs opening around our CATUs. So those models of care, particularly for intermediate care, are going to be really important. There's a piece of work that's happening with Plymouth, and we talked about it at the board to board. They're working with Getting It Right First Time in looking at alternatives to ED and to admissions. So we have decided that we would join forces with Plymouth, because as we all know, 20% of our population faces into Plymouth. But also I think there may be some really good lessons for us as well that we can share with the work that's already been done within RCHT. And it's not just about acute admissions, it's also across the board, across all pathways, including mental health. So whilst we've got an improving picture, we're only too aware that we're still not seeing that smoothing effect of discharges. So we're still seeing discharges dropping off at weekends, which then puts us into a difficult position on a Monday and a Tuesday. And also we're still not seeing the traction on getting discharges out before midday. So some of those really what feel like fairly small actions in a big piece of work that we have to land, they're incredibly important, because if you talk to our ED consultants, and having been a coup for many years at RCHT, they tell you if you get ED cleared by midday, you've got a cracking chance then to get the hospital flowing for the rest of the day. So I know that's something that RCHT is working really hard on, and some of that is a cultural issue, which we know that ESIST are working on with RCHT, and it won't just be in RCHT; it will be across the county. We often talk about Cornwall being a bit of a grumpy teenager and not getting out of bed before midday. We don't get started, do we, until after 1 o'clock, which for our patients isn't a great experience, and we know that it has a knock-on effect to flow. So I think some great work's been done, but there's still more work that needs to be done, particularly as it's fragile. And as we've seen last weekend, we had ambulances queuing again, and we absolutely cannot have that. Thanks, Kate.
Thank you. Simon?
Okay, I should just highlight this sort of up to date on the finance position. So we continue to forecast a break-even position for the system, but that's underlined by a very difficult position being reported to date at month 2, and also going to be reflected once we've been through the numbers for month 3 as well. So what I would highlight is there is a significant piece of work to be done in the short term to reassure ourselves as organisations and as a system that we can deliver what's required to get back on track in terms of a break-even system break-even position across our organisations. We have external support has come in, and that was planned, and that should support us in improving our positions. But I think there's a lot more we can do as individual organisations to work through. The two things I would highlight, as usual, the system and colleagues would be very familiar with cost improvement, value for money programmes still prove to be challenging to deliver. That's one area that we have to show a demonstrable difference of movement on over the next month, 2 months. And equally, this is an issue across the NHS and South West. Agency spend continues to be a significant factor in affecting our overall financial position across organisations. So that's one of the areas that needs massive focus on, and we need to be reporting back on over the coming weeks. So I was going to leave it at that for now, Kate, and Chair, and take questions later. Thank you.
Thank you. The final point I just wanted to make was this should be the last month that we have the performance report in this format, that in September, we should have the new truly integrated performance report, which will be developing over the next 6 to 8 weeks with input from many of you in the room. Looking forward to that. So thank you.
Thanks, John. Yeah, just to pick up on a couple of those points, if I might. I suppose firstly to feedback from the Finance Committee, given Sanj isn't here, and just say, the Finance Committee were looking also at the month 2 numbers, and I suppose express some concern, that that the plan was already somewhat off track, which is surprising given it was only really agreed not long before that, but also that although this is the month 2 numbers, in reality we're always into month 4 and soon to get into almost halfway through the year, so the time to catch that back up is actually reduced. So we perhaps can discuss some of that later, but just wanted to feedback that the committee were expressing a certain level of concern, even though a relatively small variance, still quite difficult to pull back. A question more generally was just on the elective work, and I know we've talked a couple of times around orthopaedics being the biggest local problem, and for some time I've talked about, I think, procuring some solutions out of county potentially. I just wondered, has that now come to fruition? When's it going to start, and are we going to see some impact on the waiting list for orthopaedics?
Thank you. My understanding on that, it's a mix. So some has been procured already, but there's still more to do, which is why we haven't got a finalised 65-week plan with the trajectory against it. So it's still a work in progress.
I'm right that that's the biggest single contributor to the 78 and 65-week problem, isn't
yes,
it?
Yes.
Okay.
So I'd like to build on that really. I think we need to decide within the next month whether there is any likelihood of us being able to commission significant quantities of out of region elective activity, so that it impacts not just on 65 weeks but on 78. And my question was around, we're in tier 2 for elective recovery at the moment. If we were supposed to hit 78 weeks by the end of July, it's now November. Does that affect our tiering status? Are we likely to be escalated to tier 1?
I haven't got a crystal ball on that, but my conversations with Martin would indicate not at this stage. I think it's the bigger picture around 65 weeks and the confidence to be able to improve through the rest of the year towards March 24.
Now I can ask that for our next ICB in September, that we have quite a detailed commissioning plan for orthopaedics, almost by specialty to provider, that then allows us to know whether we're going to get the volumes that we need to hit 65 weeks, because if not, we're going to have a focused discussion on what we do.
No problem. We're expecting that plan in about 2 weeks.
You could minute that. I'd be very grateful. Thank you. So, just 2 questions from me, Simon. One is, with what you're saying in terms of the state of the finances, given the fact that, I'll pluck a number, 75% of our cost base is staffing, is it fair to say that's the place that's most out of control, or is there other areas that are dwarfing the impact on staffing,
I think, as you highlight, staffing is the most significant area, and it's the one area that if we manage, and when we manage better, it'll improve our position significantly across all our organisations.
This question is aimed, Kate, towards back to you, which is, I didn't really hear too much about SOF implications more generally in that debate. How are you in the integrated care performance report really focusing us on SOF?
So in terms of SOF, and SOF is on the agenda later this afternoon as well.
Yeah, but we're in public now, so I'm just trying
No, absolutely. So I think it is worth noting that there has been some progress made on a number of areas on the SOF agenda, specifically, that relate to urgent care. So it's the general and acute bed occupancy, the 14-day length of stay, and the 4 hours in ED, which is really good. And there are detailed plans for all of the metrics either being developed and or being implemented across all the range of metrics, but we're pulling those together into one place, and then we need to work out how that fits with our governance infrastructure that we talked about earlier, the SOM and the quarterly reviews that we talked about. So that's probably all I would want to say at this stage.
Okay, so let's move to the recommendations, if that's all right. Having looked at the recommendations, I suggest that what we're also doing here is this going to be the almost the last of the current format of integrated. Fine. So
That's the plan.
yeah. So I think if that's the case, I think we should recognise that we've taken some form of assurance from the pack, noting the issues that you've raised in terms of concern, both from a quality but also a finance perspective. So we're noting those. And what we're hearing is that you're going to be bringing something back in September as a plan to deal with that, along with a new genre of integrated performance report. Is that fair?
Yes.
Rachel?
There's been specific issues raised, and it might be because it's highlighted in red, but the cancer performance statistics are very bad. I feel like we can't move forward without us noting that as a board, that's an area that we should be looking further into. Is it scheduled?
So Ella's here, but I'm going to say what I think's underneath that. So we know that our cancer standards aren't picking up as fast as we'd like them to, and in part that relates to access to diagnostics. We have new community diagnostic hubs coming online, and we have additional elective surgical activity, access coming online at St Austell. So both of those things will help us. But I think it's a good point, Rachel. And when we bring the plan back about 65 weeks, we should bring the recovery plan back for cancer, and by cancer type that's driving the overall position, because it isn't across the board. Some pathways are more challenged than others.
Thank you. And what you've picked up, Rachel, thank you for doing so, is that the new genre is actually going to make sure we have front and centre these really high profile main core areas. But Ella, did you want to respond to what Kate just said?
Just to add, I suppose, the reassurance that cancer standards are getting equal priority in terms of attention from RCHT for urgent and emergency care and elective. So I think it's a really good idea we bring back, same as we are for the electives, the cancer.
Okay. And we need to bring UHP along side by side, because UHP's cancer performance has improved enormously. So we need to learn from what they've been doing so that we can bring that into Cornwall facing services.
Thank you for raising that, Rachel. Okay, shall we move on? Happy with those recommendations? Yeah, we'll take those. Thank you very much, Kate. So we're running just slightly behind. I think that's okay. So in terms of forward plan, two things there. I'm going to throw it out there. September is going to be a heck of a board. So I think the suggestion, based on the conversation that we had, Kate, is that we clear the decks for September, other than a very few number of items. Yeah. Anything you want to tease out as to what those might be, so everyone's clear?
I'm just making a note of all the things that we're talking about coming back for September, October, November, but we will have to keep the September one very light, bearing in mind the AGM. So I think we'll have to agree between us 2 or 3 key items, bearing in mind that finance and recovery will be probably a big part of September.
I really think the forward planning of September, October, November, December, please, as an executive group, can you have a think about the journey of that and what needs to be done, both tactically and strategically, to ensure that we cover off both? Yeah. Any other observations on the forward plan? No? AGM, all going to go well there? Yeah. Thank you. Good. Just wanted to be reassured.
So we have a venue.
Okay.
I'm looking at, we still have a venue, haven't we? So we've got a venue, and we're planning it more as a True North type event of engagement with people who work with us across our county and the Isles of Scilly around services, rather than us talking through our annual report, and that we almost use it, going back to, I can't remember who said it, but you said and we've done, so that there's an iterative feedback to people around how we've engaged and how we've worked with.
The date?
14th of September.
Okay, thank you very much. Okay, so now we go back to the agenda, looking at agenda item 23, which is questions from members of the public relating to the agenda. So if anybody wants to ask? No? Okay, thank you very much. In which case, at 3 o'clock, I'm going to close the meeting for part 1. Thank you very much, everyone. Let's leave that there.